Midazolam, fentanyl because it's very painful, and then propofol. उधर दिखा दो propofol. देखा होगा तो सबने. So this has to be done under sedation. So you have to have an anesthetist under attendance who would help you out. Oxygen लगा दो. Oxygen.
So previous sensory was at 0.6. Now this sensory is at 0.1. So what is the difference between the two?
I pulled out the needle a little bit.
Okay.
I thought I was just too much inside the foramen.
Okay.
So I
So
pulled it out.
you are more near V3 than V1.
Yes.
Okay, sir.
No, I was not near V1, but even V3, I was not having a good stimulation till a very higher current. So now, once I pulled it out, I am getting at 0.1 and 0.3 in motor. So always once you give sedation, you have to give oxygen by nasal prongs. And once the patient is sedated, we will do the stim. अब एक कैमरा उस पे मशीन पे रहेगा. Ablation. So impedance is 198. This is the probe temperature at the moment, 37, but we will increase it to 50 degrees. So this the protocol which I follow is start at 50 पे आ जाइए. हाँ जी. So we give it for 1.5 minutes because it takes about 20 seconds to achieve the temperature. All set please. All okay. और propofol दो. और propofol दो. अभी आप रहने दो उसको मत छेड़ो. नहीं मत छेड़ो. एक बार आप you can see the ये हमारा ही है ना. You can see the lateral now in relation to the foramen, in relation to that line and clivus. You can see so beautifully inside the foramen, not very deep inside the foramen.
Show us the X-ray.
Yeah. Please दिखाओ इसको. ठीक है जी. So now sedated, we will be starting the ablation. Yeah, इधर दिखा रहे हो. So this is now impedance. You have seen temperature set is 50 degrees for 1 minute and 30 seconds. Start please. Start. Keep a watch on the vitals please. So it takes about 15 seconds to achieve 50 degrees. Once we have achieved that, the ablation will start. Yes. So that's the time elapsed. 50 degrees. Patient is well sedated. He is not having any pain because of the ablation. Because once you increase the temperature, they can be sometimes very painful and unbearable. So I start with 50 degrees, go to 60, 70 and 80. If you are doing maxillary, you can top it at 70, 75 also because it is in close proximity of V1 and you would never like to ablate V1 with the standard radio frequency. Or V1 either you can use a pulse radio frequency or you can end up at temperature of 50. But generally we don't do throw propofol or please.
Sir, do you change the needle tip position when you are doing the second and third?
No, we don't change.
You
We don't
don't.
change. If we have got a good stimulation at this, I will not change at all. इसके बाद 60.
So when we are putting in the needle,
जी.
some recommend that we should feel that margin of the foramen. Bony margin should be felt first,
Yeah.
so that we are sure that we are
Yeah,
at that level.
absolutely. I do agree. But only thing is that if you hit it hard, your tip of the needle may sometimes become blunt. So you got to be very careful. Yeah, but that's a good, if you see this foramen, you could see it was a very big foramen. Sometimes if you think it's a dicey type of thing, whether it's a foramen or a small foramen, then it is better to go and hit the margin and then come inside, come medial to it, if you're doing a V3. Raju, please, 60. So now we are going for 60. So it's a 4 minutes or 6 minutes process by which you do the ablation. And after that, I don't put any drug in the needle and just take it out. But there are people who put some steroid, local anesthetic. Please, if there is a CSF, don't do anything. Just come out. And this is the only intervention where you give a prophylactic antibiotic. So right in the right in the recovery room, we'll give 1 gram of monosef and continue oral antibiotic. Sometimes there could be some pain after the procedure, so you can give an anesthetic for 4-5 days. And whatever the drugs patients are continuing, lower the dose. Supposing he is on carbamazepine 800, 600, just give about 400 for 15 days. Tell him that there could be some sparks for a few days, and after 15 days he is pain free. I don't call them for any follow-up. No need for any follow-up. The only complications which you can have is sometimes dysesthesia, unpleasant sensation, no pain. Obviously, this pain will not come back. Propofol, please. Propofol. So this pain is not going to be there, but those unpleasant paresthesias can be there. So ideally, you have to reassure, give some anti-anxiety, give some drugs which can help him. Otherwise, nothing much is required. And within a month or so, this unpleasant paresthesia, please give more propofol.
So, sir, ultimately, the needle tip,
Ji.
is it inside the ganglion or is it inside
No,
the
no.
proximal root?
Just proximal to the root.
Just,
I mean, no, you don't, you
proximal.
can't enter the ganglion. It is so painful.
Okay.
Yeah, when you touch the ganglion also, patient exhibits severe pain.
So there's nothing to guide the beginners to avoid entering the trigeminal ganglion.
See, ganglion, I mean, as soon as you hit the nerve, patient will have pain. If you go further in, if you enter the nerve tissue, it is very painful. He will jump actually. There will be no guidance required. He will jump from the tip. So don't attempt that.
Sir,
Yeah.
do you want to say that our needle is near the needle but not into the nerve?
No, never into the nerve. It is just very close to the nerve. That's why the stimulation, if supposing I get a stimulation at 0.10, I will withdraw the needle, like what we were doing, getting.
But there should be physical contact of touch between the needle and the nerve, only then the nerve will get
No,
away.
not really, because the lesion size is about 10 to 15 mm.
Okay.
So we have good enough period of, the length of lesion or the diameter of lesion. So even if, obviously, if you are far away from the nerve, you won't get stimulation up to 0.8, 0.9 or 1. So if you are close to the nerve, then only. So that's why we have given a range. So you get up to 0.5, you are close to the nerve, but you are just few millimeters away.
So
If you are touching the nerve, then patient will exhibit pain, obviously, 1. Second, stimulation will come at just 0.1. So in that case, I will withdraw the needle just few millimeters. And I will aim at 0.2, 0.3 volts at which I should get the current.
So this impedance that we take guidance from, like it should be below 500.
Below
So
500.
what does that mean? Actually, the needle tip is near the needle.
Needle tip is near a neural tissue, not opposite a bone or a hard structure. If it is touching a bone, the impedance would be very high.
If it enters the root, what will happen to the impedance?
Then the impedance would be very, very high.
Is there any difference in the impedance of the root and the ganglion?
Not really. Same nervous tissue. So it will be same.
Sir, if like in this case the CSF was coming,
Yeah.
will that insulate against the radio frequency ablation in the sense?
Not really. It doesn't matter.
Okay.
The CSF is not going to affect your lesioning or insulation. Not at all.
Sir, the time was bifurcated in two parts. One was ramp time. So what is this ramp time from 0 to 70, whatever time you have set? That is the ramp time or what?
No, that's the RAM time. Yeah, it is a RAM time to achieve the temperature.
Achieve that
The tip
temperature
of the
from
needle
0 to that
takes
level.
about 15-20 seconds to achieve that temperature. So the lesioning starts once the temperature is achieved. So first 15 seconds there would not be any lesioning which would be taking place.
So for spinal root, we are doing RF with the same machine, na, sir?
Yes, with the same machine.
So in that case, you abandon when the CSF starts coming out.
Yeah, obviously
In
you
this
don't.
case, you don't.
No, you don't abandon, but you would not like to enter the dural sheath because you have enough. The dorsal root ganglion is outside the neural sheath, so your target is DRG. So if you are entering, that means you are close to the epidural. Then that's not the target place. So if you are having CSF while doing a root block, then you have to withdraw the needle.
Okay.
Yeah. So we have finished 50, 60, 70, 80, 1.5 minutes each, and that's the end of the ablation.
Okay, sir.
So there are some. If you want to be very sure, you can check the corneal reflex after the lesioning, whether you have done anything to the V1, and that's all.
So 2-3 clarifications.
Please.
Why don't we do V1?
V1 because of the corneal dysesthesias which happens, and they can be very, very unpleasant, very unpleasant. So that's the reason. So, and there could be some loss of corneal sensations also. Corneal ulcers can happen. So because it supplies the cornea too. So that's the reason.
Is there anything else you offer them, sir? V1?
Yes, yes. We do a supraorbital nerve block. The easiest thing to do. Just go on the supraorbital ridge and put some alcohol. So V1, I don't touch it. I mean, although there has been lot of things in the literature saying that you मेरे को एक gauze piece देना, sister.
And just in your experience, like suppose you do 100 cases,
Yeah.
how many will be combined V2, V3?
There would be about 30% combined V2, V3.
And rest will be divided among V2 and
Mostly it is V3, followed by V2 alone, and then 20 to 30% both. And there would be isolated V1 also, about 5-7%.
Thank you, sir. We shift to OT
Okay.
44.
Thank you so much.
Thank you. OT4, Dr. Ashish.
Yeah, hi Deepak.
Hi, Ashish. Sorry to keep you waiting.
No problem at all. ये इसमें lateral वाला दिखाएंगे क्या इसमें? So first of all, I would want to show you where exactly I want my needle to be.
Right.
So suppose now this is the AP, the disc pro. Sorry. Oh, I'm sorry. So मैं इधर से हूँ क्या? This is better.
हाँ, better,
Okay.
better.
So this is L45
Full
disc
screen कर लो, full screen. हाँ. Yes.
So L45 disc herniation, what we have done is we have made this absolutely parallel, so there is no parallax.
Right.
For a transforaminal block, I'll have to take my needle here and I can place up to the medial pedicle line here.
Right.
Now suppose if I want to do a transforaminal discectomy, then I'll get my needle here.
Right.
Suppose if I want to do an extraforaminal discectomy, then my needle placement would be here.
Okay.
Depending on whether I am taking a transforaminal endoscopic route or a para-PSLD route, interlaminar para-PSLD. So what I'm trying to suggest is this needle, learning this technique is important because there are a lot of things that you can do with this approach.
Right.
And that is why ideally this patient, we can do a L5 root block here, but I'm trying to demonstrate so that you can appreciate all this that you can do. As far as the lateral approach is concerned, if you look here, my ideal point of needle placement should be here. That means with this approach, you can place your needle anterior to the theca where the pathology lies. So I can put it here. A little bit inside, I can go, that would be for transforaminal discectomy. So
Okay.
and now I would also want to show you the needle. This is a little different sort of a needle. It is the transforaminal needle. So, ये needle दिखाएंगे? So this is the needle, if you'll appreciate. It's a long needle. Okay, because through this, the K-wire will go and then dilator and endoscope.
Okay.
But here, obviously, we are just demonstrating the block. Now,
What is the length of this?
this is about 18 centimeter.
Okay.
So here we have done some markings. Now, the most important marking is this lateral marking. Can you see this?
Yes.
Now, how come I have reached to this point? Okay, that I'll show you on lateral X-ray दिखाएंगे, हाँ. So, can I get an artery for some? Now, on lateral, there's a study published by Rutten et al. From Anna University. So, what they say is, if you want to approach transforaminal L45 or L34, your entry point needle cannot go beyond this hump of the facet joint. Higher up, as you go higher up, your needle cannot enter deeper to the edge of the spinous process. So I'll show you on lateral what I mean by this.
Okay.
Okay. So I'll start. This is what my marking is here. So we start with the trajectory is almost straight. because of the iliac crest is almost reaching up to the L4-5. So I have to go a little superior. So, and a lot of work is done by the bevel. So the bevel will decide where the needle will go. So wherever is the bevel, the needle will flow accordingly.
So how have you decided this lateral entry point?
Yeah, I'll show it to you.
Okay.
On the lateral. Shoot, please.
PIP में रखो हाँ.
Dr. Ashish, have you given any local anesthesia
Yes, yes,
along the
yes.
tract of
Yes.
the needle?
No, not along the track, just
Only
at
at
the
the
entry point.
Only at the entry point.
Shoot,
Okay.
please. Okay. Bus. Shoot, please. Shoot, please.
Any IV sedation?
No, nothing.
No, no.
Patient
The
is fully-
patient has to be counseled regarding this pain then
Yes, yes.
before the
Little-
procedure,
little bit.
because if he is not counselled, then he might jump for with this pain.
Yeah, but they generally don't have pain.
Okay.
Shoot, please. बस सर झटका मत लीजिएगा please.
How do we assess the anterior posterior direction of the needle?
Yes, that we'll have to do with the lateral. Shoot, please. But we start with the AP so that we don't, cross the medial pedicular line.
Okay.
अब lateral कर दीजिए. So for a block, the best position is the inferior end plate of the superior vertebra.
Okay.
That is one of the best positions. हाँ, ओके, इसको सेव कर लीजिए. शूट प्लीज. Okay, so here I am a little posterior, so my bevel will look down. Shoot, please. Okay, can you see?
Yes, we
It's
can.
into the foramen, but I am a little superior. Shoot, please. Okay, this is the posterior part of the foramen.
Right.
So, ideally for a disc case, I have to go more anterior. Bus. Shoot, please.
You're trying to go anterior or?
I am trying to go anterior so that I can show. Yeah, shoot, please. Okay, this is a very, very good position. You see, the disc herniation is just there. You
Right.
agree?
Right.
Yeah, chalo, AP karo. Now again, I have to confirm that, I'm not penetrating too much deep.
Dr. Ashish,
Yeah,
this trajectory,
no, ऐसा उल्टा कर रहे हैं. Yes, sir.
will it not could have been shorter if it would have been parallel to the end plate?
Yeah, but then we have that peritoneum coming. So that is what I was trying to say, sir, that when you are at L3, L4 level, don't get your entry deeper to the hump of the facet joint. See, again, artery dena. I'll again try to explain what I mean. So, sir, this is the abdomen here, and the peritoneum is coming like this. Okay, so this is for L4, L45, L5, S1, L34, your entry cannot be deeper to this, otherwise there is a risk of injury. The peritoneal structures, if you go a little bit deeper. So that is why here at the lower levels, you can go deep up to this point. However, for the higher up, the peritoneum comes still higher, means posterior. So here you can't go deeper to the spinous process tip.
No, my question was this trajectory appears to be coming craniocaudally, no? Like why was the entry point not more caudal?
Oh, that was because of the iliac crest.
Okay.
The iliac crest, you can see this is medial.
Okay.
But here the iliac crest is still touching, so I wanted to go a little above that.
Right.
Yeah. Shoot, please. Okay.
And this needle is actually going through the abdominal wall only?
Sir, it is going through the back muscles,
Uh-huh.
posterior to the psoas. Shoot, please. बस थोड़ा पता चलेगा. Shoot, please. So now I am inside the foramen here. बस. Shoot, please. Okay, so you see the location of the needle. This is a fairly good location. I can go still inside, touch almost up to the medial pedicular line.
So Ashish, you actually did you use the needle tip to follow the bone or what for the foramen to get inside?
So
or you
foramen, see, Deepak, we know that we can see the foramen very clearly.
Yes, we can see it.
So never try to hit anterior. If
Okay.
you are hitting anterior towards the body, chances of complications are higher. You can make an error going posterior. That won't be a problem.
Okay.
Shoot, please. Shoot, please.
We seem to be inside now.
Yes. Shoot, please. But I am, and I'll also show the root. Just give me some dye, little bit of dye. Shoot, please. Okay, this is the root. You can see the root.
Yes, yes.
Okay, but this is not what I want to block. Because this root is not the
Culprit,
problem. Yeah.
yes.
So that means this location is not satisfactory and I'll have to reposition my needle. So if I wanted to do a discectomy, it would have been easier. Shoot, please. Shoot, please. Shoot, please. So this is the position for your transforaminal discectomy.
Okay.
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 I'll just show you on lateral as well. Lateral kariye. Also, you can do a discography if it comes to that.
Right.
इसको सेव कर लीजिए. Shoot. So this is an ideal location for your docking of your endoscopic transforaminal discectomy.
Okay.
This will give you either a complete inside approach or a mid inside outside approach of your trocar and cannula. Okay. Shoot करिए. So now I have pulled it. Shoot, please. Okay. Sorry, beta. 1 minute. Shoot, please. Okay, this is bang in the center.
Yes.
Okay. AP, please. So what I was trying to demonstrate that you can put your needle just at the lower edge of the upper vertebra. You can put it inside the disc. You can keep outside the disc anterior to the theca. So you can do a lot of things.
Right.
Shoot, please. Die.
Dr. Ashish, where would be the,
Done,
like,
done.
without the dye, how will you know where the root is?
Well, okay, yeah, that's a very good question. So as we know, sir, that shoot, please. Shoot, please. Bus. Okay. Yeah, good. Now another artery. So, sir, we know that I'll show here. At this level, the exiting root kisses the pedicle and it comes out like this, the exiting root.
You have to come on the main screen. Actually, PIP should go.
No, we can see this arrow.
Huh?
Acha, we can see the arrow.
Okay, so here the exiting root is going to come like this. The traversing root is going to come like this and then it is going to exit from here.
Right.
For this level, the exiting root is going to kiss the pedicle and come out, and the traversing root is going to come here and then it is going. So for this disc, ideally, the needle can be placed somewhere here anteriorly. That will be much better.
But when we do a microdiscectomy, is this enter disc, is it not the exact place where we, find the root and we deflect it to one side?
Yeah, but that you are reflecting is the traversing route. For a microdiscectomy, you do not generally touch the exiting route.
Mm-hmm. So how are we protecting the traversing
Shoot.
that route?
Okay, so you can see the root here.
Hmm.
Okay, now shoot, please. So don't cross the medial pedicular line. That is the still it then. So if you are not, because the traversing route will be sticking to the theca.
Right.
So that means it is within the medial pedicular line.
Right.
So don't cross that.
Ashish sir, can we identify traversing route by putting the die?
Yes.
So where can we anticipate our traversing route?
Yes.
Because this diagram, die is showing us the exiting route, not the traversing route.
Yes. Shoot, please. Shoot, please. Shoot, please. Shoot. Still. Shoot, please. So this is the medial pedicular line here.
Okay.
And if I have not entered the disc, then we should be able to see. If I have entered the disc, then you'll have a discogram.
Okay.
I think. Shoot, please. Okay, there you see the traversing route. Do you see?
Can you point out
Yeah, why
specifically,
not?
please?
दिखाना. It's very clearly seen. ये दिख रहा है ना? ये आ रहा है? ये black thing?
Okay, okay, okay.
ये यहाँ से यहाँ तक आ गया. We can see up till here. Can you show the previous AP without this dye? So practically, Rajiv, Deepak, we can do a traversing root block, exiting root block, and an epidural with this.
Right.
Okay. So on lateral, you can see this is the exiting route here. And मुझे आप ये वाला नहीं with dye वाला ये वाला picture दिखाओ ये वाला. See here, you see this picture?
Yes.
Now show me वो अभी जो recent वाला था इधर. I'll show you the two. Okay. Now नहीं दोनों इधर इधर लाओ ना. ये वाला इधर कर दीजिए. So here you see this is the traversing route pura.
Correct.
Okay, this is the dye. This is the exiting route coming here. So look here, this is the exiting route, and here this is the traversing route,
Correct.
and here is the shoulder somewhere.
Very nicely said.
Okay.
So, Dr. Ashish, just to repeat the things,
Yes, sir.
the traversing route is more
Done.
vertical than the exiting route, isn't it?
Yes,
Yes.
sir. Traversing route is still within the thecal sleeve,
Yeah.
and at the level of disc. I mean, we know that, sir. If it is at L5S1, it sort of comes out a little higher up. But at L4-5 level, at the disc level, it will be still sticking to the theca. मेरे को drug चाहिए.
So, when we do a traditional microdiscectomy,
Sir,
at L4-5 level, what we are relieving the pressure is of the exit,
no, of the traversing route. Traversing route.
And where is the exiting route at that time?
It is cranial, sir. It is much cranial.
And if that is compressed, then we have to go a higher level.
Yeah, you can just tilt your tube, endoscope, whatever, and go a little up, sir. Like, sir, for in our routine cases, sir, when we do mys-TLIF or endoscopic fusion, we always try to see the exiting route, because in TLIFs, it is not the traversing route which will get injured.
Yeah.
It is the exiting route that gets injured.
No, in most of the microdiscectomies, the traditional microdiscectomies, it's the exiting route only that we are decompressing.
No, traversing route, sir.
Traversing route.
Yes, sir.
But we are able to see nicely the shoulder and the
Yeah,
root
so
is
that
exiting
shoulder,
out.
sir, that shoulder is of the traversing route.
Okay.
And if you follow it inferior, then you have the axilla of the that becomes the exiting lower down. अभी मैं दिखाता हूँ, sir, वो भी.
Actually, this nomenclature is only regarding the disc that we are operating. Otherwise, they are the same, no? And it's the level that is different. No?
Yes. Now you see kitna drug. I have just injected 1 cc and the whole thing is getting epidural. तो चला ही गया है. Steroid, please.
Sir, for both exiting route and traversing route, both you have used 1 ml separately. Am I right?
No, I have used 1.5 cc
Total.
total.
Okay.
And I used Decadron So I have given Decatron also. Should
So,
please.
dye has to mix with Decathlon
No. Separate.
separately. Okay.
Abhi you see the whole dye has been washed out. Just to complete, एक बार lateral और दिखा दीजिए हम कहाँ पर हैं.
And how much time we can expect that this dye gets washed out from our operative area?
You mean to say, matlab, if I leave it just like that?
Yes, sir. Yes, sir.
Oh, okay. Rajiv, तुम out of course question पूछते हो. Dureja sir, you just, if Dureja sir is around, I haven't got an X-ray or read about it.
अच्छा अच्छा अच्छा. Okay, boss.
Okay, here you see the root. So, जो तुषार सर पूछ रहे थे ना, so सर ये देखिए, ये exiting route है, and exiting route is coming from here.
Okay.
So ये यहाँ जा रहा है. This you see is extra discal, extra foraminal.
Yeah, no,
This part.
Let us name the vertebrae also. We are seeing
Okay,
L4 and 5.
so for a L4-5 disc, it is the L5 root
Right.
in a central disc herniation or a paracentral disc herniation.
Right.
When you have a foraminal disc,
Yeah, then
there is a chance of exiting route, and for extra foraminal disc, it is mostly the exiting route.
Right, I got it.
Yes, sir. Okay, एक बार हाँ short ले लिया ना. Okay. So see, we are beautifully located anterior to the theca, posterior to the disc.
Okay.
Okay, so this is a good location, and I think the procedure is done. If there are any questions, I can take.
Dr. Hitesh is asking how many X-rays you normally do for one person?
So for transforaminal, you can maybe around 8 to 10, at times 12.
Okay.
Around 8 to 10.
10
This
is
is
that-
another very good question. So Deepak, the reason why we have graduated from transforaminal discectomies to interlaminar endoscopic discectomies is because in interlaminar endoscopic discectomy, you just shoot 1 or 2 X-rays max.
Okay.
2 or 3. Whereas in a transforaminal discectomies, endoscopic, you have to do you give a lot of radiation to yourself and the patient.
So what drug did you give Ashish here?
So I have used preservative-free bupivacaine, 0.25% along with dexamethasone, which is a non-particulate. So I have
How much Dexa you gave?
I have given around 4 milligram of dexa to him.
4 milligram Dexa with bupivacaine.
Yes.
0.25.
Yeah,
Okay.
yeah.
Thank you, Ashish.
Thank
Excellent
you.
demo.
Thank you.
We shift to OT5, Dr. Dureja. Yes, Menaz.
Hello, sir. Hello.
You are in OT5.
I am in OT4, sir. Our third case will be another trigeminal neuralgia.
We'll come to you a little later.
Yes, sir.
We shift to OT5.
Okay, sir.
Time लगेगा. अच्छा, we shift to OT4. We shift to OT4, sorry. Menaz, please continue.
Yes, sir. Our
Ashish said to please go to OT4 for the trigeminal case.
sir, in OT4,
Yeah, please
we have
continue, Manas.
our third trigeminal neuralgia patient, sir.
Yeah, this is secondary trigeminal, I think.
Yes, sir.
Yeah.
This is patient Hukum Singh. He is a 61-year-old male who works as a mechanic by profession. He has complaints of needle-like pain over the left side of angle of mouth and along the cheek. It's mainly towards the V2 distribution of his cheek. And he has this since the past 1 year to 8 months. 8 months, it's been more severe, sir. It was insidious onset, gradually progressive, and he does not have any other comorbidities or complaints. On examination, his cranial nerve examination showed that there's a needle-like, he complains of a needle-like sensation whenever we touch the V2 distribution of his face, sir. And there's no sensory loss or there's no loss of motor function. And rest of the cranial nerve examination is normal, sir. On imaging, we've done a CMRI brain. I'll be showing that to you, sir. It shows a 33 into 21 into 28 mm T1 hypointense and T2 hyperintense, non-enhancing, diffusion restricted, extraaxial lesion in the left cerebropontine cystron, sir. It's compressing and the brainstem. Query epidermoid cyst. This is his MRI, sir. This is the MRI. We can see the cyst, sir. This patient has been taking Tegretol 200 mg TDS since the past 1 year, along with tab pregabalin HS, and he's been taking tramadol SOS. In spite of that, he had no relief of pain. No other surgical intervention was done prior, sir.
Dr. Menas,
Yes, sir.
when there is brainstem compression, that why don't we offer him surgery?
So the size was small, and he
No, we,
like
it's very simple reason. At AIIMS, the waiting list is very long. So by the time his number comes, at least we can relieve the pain. That's all. Epidermoid cyst may not respond to. Trigeminal we can give the gamma knife, but because this is the workshop, I mean, you can, there are various ways of skinning a cat. This is one of them. So Dr. Ashish,
Hi.
we are back with you.
Yes, yes. So we are just about to set up. इसका height बढ़ा दीजिएगा. So this gentleman, I think history you all guys know.
Yes, yes.
It's a short history, but he had poor response to medicine. अभी मत डालो.
Right.
लाइए सियाम लाइए देखिए. हाँ थोड़ा ज़्यादा हो गया. कम कर लीजिए. थोड़ा कम कर लीजिए. बस. Thank you. लाइए. मेरे को can I get something to clean, please? Something to clean. Sterilium and gauze, please. Yeah. आ जाए. Okay. बस. पीछे लीजिए, अपनी तरफ लीजिए. ओके. और ऐसा टिल्ट कीजिए, इसका हाइट बढ़ाइए. ओके, हाइट बढ़ा दीजिए. ये साफ कर रहे हैं. हाँ, ये इधर चाहिए मुझे. अपने तरफ लीजिए. और उधर. हाँ, थोड़ा सा टिल्ट करिए. और हाँ, शॉर्ट लेना. शॉर्ट में इसको थोड़ा साइड कर लेंगे. फैक्टर इंप्रूव करिएगा. फैक्टर इंप्रूव करिए. शूट प्लीज. कुछ नहीं आ रहा है. शूट. बहुत ज्यादा हो गया. ओके, ब्यूटीफुल. थोड़ा सा और टिल्ट करना. थोड़ा टिल्ट करिए. ऐसे. हाँ, शूट करिए. शूट करिए. ये बीच में ये रॉड सी क्या आ रही है? थोड़ा पेशेंट को नीचे लेंगे क्या? और आप भी सियाम नीचे लीजिए. हाँ, नीचे ले रहे हैं बाबा. नीचे ले. थोड़ा नीचे लेंगे. जाइए. और नीचे जाइए. और नीचे जाइए. हाँ, ठीक है. ओके, नाउ शूट प्लीज. ये थोड़ी देर के लिए इसको हटा, पीछे कर देंगे. दिख नहीं रहा है मुझे. थोड़ा पीछे कर दो प्लीज. हाँ, शूट प्लीज. ओके, दिस इज बेटर. अब आप उस तरफ टिल्ट करिए. बस. हाँ, अब शूट करिए. अब शूट. और थोड़ा टिल्ट करिए. और टिल्ट करिए. ओके, बस. शूट. Okay, guys, so you cannot see a better foramen ovale. Hana, it's a beautiful. So I have not given any. This is just a neutral position. And if you see here, beautiful foramen ovale. Deepak, are you there with me?
Just coming back in 2 minutes.
Oh, okay.
Rest of us are here.
Okay, sir. So can you see ovale, sir?
Yeah. Yes,
So again, the H which I was showing, and every structure is very beautifully seen. The coronoid process here, the maxillary sinus and the molar here, and the petrous, and look, here is the temporomandibular joint which is seen. So just below that, if you have the petrous, that is still better, and just above that you have the foramen ovale. So I'll draw.
Ashish, some people adjust the submental view so that the width of the ovale becomes a little more. Have you tried that? No?
I'm sorry, sir, please come again.
The width of the ovale,
Yeah.
that little bit can be adjusted by changing the submental view.
Yes, it can be, but your target, sir, should be generally that the foramen ovale should be in the center of your H, or in center between the maxillary sinus and the
Fine.
mandible. Okay. Chaliye, local please, gloves please. So can you focus, sir को वो देखना था, X-ray view. Tushar sir,
Yeah, we can see.
so you see the C-arm position,
Uh-huh.
you see the patient position just supine, mild, halka sa extension, nothing much. Then you are getting a submental view and a little bit of tilt.
We can have
थोड़ा
a
सा और
submental
tilt
view on the PIP.
थोड़ा सा tilt और करिए, हल्का सा.
That has gone away. PIP.
बस,
for
या.
X-ray.
अब shoot करिएगा. Okay, now, sir, this is what you,
Yeah.
as I have changed, the width has increased a bit. You can see the right and the left. Right and left में फर्क दिख सकता है. And now also there are around 5 to 15% cases where you can have calcification in the foramen ovale, and you may not be able to, see, penetrate. So that is always there. And especially in trigeminal neuralgia who are elderly, you will have more of a problem. Okay, local please.
That would be a contraindication. We would not be able to proceed in those cases.
Yeah, you can consider it as a relative contraindication. मेरे को scale चाहिए था. सूर्या mark कर देगा. Sorry, I'm sorry. ये mark कर. नहीं, ये point. ये point. हाँ, ठीक है. नहीं, हाँ, ठीक है. Okay, so एक मिनट होल्ड करना, देखो लग ना जाए. Yes, hold करना. So you see, this is the, पता नहीं दिख रहा है कि नहीं, lateral canthal line.
We can see.
So this is the lateral canthal line which I have marked. And you see, it is just as you go straight down. वो भी एक, you can consider that also as a mark. Can I get local, please? मुंह खोलिएगा. Okay. बस बंद कर लीजिए, मुंह बंद कर लीजिए. बस एक सुई पता चलेगी आपको. Okay, बीटाडीन, और तब तक लैटरल एक्सरे कर दीजिएगा. 5 mm tip. The same thing that we used last time. So now we are shifting to lateral.
Dr. Deepak is back. I think.
Yes, Ashish, sorry, I had gone.
नहीं दीपक, what I was trying to demonstrate is यहाँ पर foramen वाले बहुत अच्छा दिख रहा है.
Acha, very nice.
You can see?
Yes, yes, I
है
can
ना?
see.
You
हाँ.
see the foramen, and
हाँ.
then it is just hitting.
Excellent
Yeah.
visualization.
Yeah. Now, okay, now you save this one to the other one. Acha, okay, fine. Shoot, please. Oh, this is also beautiful.
Beautiful.
Beautiful. So we have the two excellent views. Oh, okay. Now, again, same degrees पे लेके आना. Please clean and drape.
Maybe the epidermoid has dilated also little bit. Unlikely.
Has to be a true lateral view, isn't it? The
Yes, sir. It has to be absolutely true lateral.
traditional TNT is, lateral view. with
So,
all
Rajiv,
key blades
idhar.
have to be one on both the sides.
Rajiv, you will have to put your finger in. Foramen ovale dikh raha hai. So the needle has to go in, matlab 6-7 centimeters in the lateral and the middle part of the foramen ovale. Lateral and middle part, because not in the medial, because he has V2 ka. So lateral to middle part would be ideal for us. ठीक है, चल. Sorry.
The trajectory pointing towards the pupil, is that also a guide? Good guide? Easy.
Sorry.
छूट ना जाए, क्योंकि फिर ये सारी चीजें हम तो करते नहीं है. आप लोग नहीं हुआ तो फिर कौन करेगा? तो फिर पेशेंट को खाली भेजना ना क्लिनिक में, तब डिमोरलाइजिंग होता है. पेशेंट के लिए भी होना.
So Ashish. Hello.
अच्छा है.
Ashish.
हेलो
Yes, Ashish, can you hear us?
सर मैं डॉक्टर राजेश मीना बोल रहा हूँ.
हाँ, राजेश.
डॉक्टर आशीष इज स्क्रबिंग नाउ,
अच्छा अच्छा
सो
ठीक
वी
है.
कैन गो टू OT5 अंडर डॉक्टर दुरेजा.
OT5 में शिफ्ट कर लें. ठीक है. We'll don't start without us. Wait for us. Clean drape करके wait कर लेना.
या
ठीक है राजेश, वो निरुल मत डालना.
स्टार्टिंग द प्रेजेंटेशन ऑफ OT5 सर.
हाँ, OT5 who's there?
One sir.
हाँ, Vishal, please continue.
So this is a fourth case in OT5. Is a 44-year-old male with complaint of axial neck pain and radiating to C5-C6 dermatome and no other symptoms. On examination, patient having a power 5 power in all four limbs and dependence is normal, and tone is normal. In the X-ray, there is a loss of cervical lordosis and posterior osteophyte at C4, C5, C6. An MRI was done, which shows a C5, C6 PIVD causing indentation and compression of enterothecal sac with left side C5, C6 neural foraminal compression. This is the X-ray of the patient showing lower cervical lordosis and showing osteophytes. There is a sagittal imaging of the patient showing as a medullary PIVD. And this is axial image of the patient showing there is a C5, C6 PIVD compression on the left side.
So just go back to the SAG.
Yes, sir.
So in SAG there are multiple levels. There is, it's
Yes, sir.
2, 3, 4, 5, 5, 6, 6, 7. 3 levels with both. I think it's ligamentum flavum also and anterior disc. So there's a pincer effect. But on the axial, can we see the axial?
Yes, sir.
So on axial also it's just not 5, 6. You go down, show us inferiorly. At 6, 7 also we can see some compression.
Yes, sir.
So there is 2, 3 levels. And what are the primary symptoms of the patient?
So primary symptom were paresthesias and the C5, C6 rheumatomol distribution.
So primary symptom is C5 paresthesia. Okay. And he is how old?
He is sir, 32.
Sorry?
32, sir.
Very young, 32-year-old is non-diabetic, non-hypertensive, right?
Yes, sir. No comorbidities.
There is no radiculopathy.
Sir, there's a radicular pain also.
There is no pain is also there. Pain is in which distribution?
So C5, C6, same.
C5 and C6.
Yes, sir.
And you, jerks and everything are normal, Vishal?
Yes, sir. Reflexes were normal, sir.
So there is no evidence of myelopathy.
No, sir.
So Dr. Dureja?
So, as you heard from the history, he's got a radiculopathy, and you have seen the MRI of the cervical spine, which is showing significant compression on the exiting and traversing route. Left side, hello? Left side, yeah. Left side, yeah, on the left side. And so the plan, since there is no neurological deficit, he's a young guy, so we plan to go for a cervical epidural, as you saw, and as I said, it's a multiple level, so we are going from C6, C7 into space so that we have a spread right up.
Okay, sir.
Yeah. So can you see the fluoroscope?
Yes.
Yeah, so we have outlined that place, the C6, C7,
Right.
given some local anesthetic on that place. And again, if you would remember, we used a set, ये वाला set ही है ना?
So symptomatically, it is a C5 and C6 route.
Yeah.
Which route are we targeting now?
No, we are going for a epidural. So we will be targeting C5, C6, C7, all routes,
Okay.
but preferably C5, C6
Okay.
on the left side.
Right.
As I told you that we prefer to avoid, although I will show you on the fluoro how we give a transforaminal block, but generally, as I said, because the spinal artery is close by, so we tend to avoid, and we get a good spread from a cervical epidural. So why take the unnecessary risk?
So where exactly is the spinal artery?
Spinal artery is lying very close to the nerve root, as compared to the lumbar region. So that's why there have been a number of reports in the literature about accidental, because what we use is a particulate steroid. If you're using a miscible steroid like a dexamethasone, beta-methasone, you can go for a transforaminal. But if you're using a particulate steroid like what we use, triamcinolone and depomedrol, then you got to be careful.
So why don't you favor dexamethasone?
Because it has a very short duration of effect.
Okay.
It is just like a couple of weeks or maybe 3-4 weeks.
What is being used instead of Dexa?
Depomedrol.
Depo.
So we are using a miscible steroid, which is like particulate steroid.
Basically methylprednisolone made in a depot form, so it lasts longer.
Correct.
Yeah. As you can see, I'm going slowly. I pierce the interspinous ligament. I have to change the trajectory on the left side.
C6-7. वो देखना C2 पर I counted 6-6-7. There is a special syringe. It's
Yeah,
called.
this is a special syringe. So a special set called the mini epidural catheter set. Vortex makes this special syringe. The normal usual syringe does not work in this.
It's called a loss of resistance syringe. Okay. So you can detect the loss of resistance.
This would be a cervical rib, I think. C7. We think as a first cervical rib. So for beginners, any guidance from a lateral view?
Patient को
Yeah,
full
I
screen
can
कर दो.
show you the lateral
Patient
view.
को main
Okay.
screen- Patient को main screen कर दो.
ठीक है. This is the AP view, and I have not yet reached the epidural space. Let me just readjust it. Yeah. Lateral दिखा दीजिए.
ऑडियो वीडियो पेशेंट को मेन स्क्रीन में कर दो.
Lateral दिखाइए please.
अनुज.
For the beginners, definitely lateral view would be a good guide to going into the epidural space. But as I said, most important is the feel of the ligamentum flavum. because the dura lies very close.
Right.
So in any case, it is the loss of upper kariye table,
Hmm.
but still, you will get a good guide
Hmm.
if you see the lateral.
Even neuronavigation can help the new beginners who have neuronavigation with them.
Yeah. Can you please make the table up, please?
So when we give, this may sound little basic, when we give epidural in the lumbar spine, we keep the patient lateral to open the interspinous.
See, basically, in the lateral,
Yes,
like
sir.
what we do for anesthesia.
Yes, sir.
Oh, no, that's not a very ideal situation because the spread of the drug from the lumbar is a very wide space. It's generally linear. So here you will see it's a small narrow space. So the drug spreads into the root. But in a lumbar it goes higher up.
Right.
It's without going into the roots. So that's not desirable. That's why we abandoned using a lumbar epidural. Otherwise, when I started in the 90s, we were doing only sitting lumbar epidural and giving steroids.
Okay.
But obviously, at that time, obviously the results were good because patients' expectations were not very high. But obviously, we're not giving targeted drug,
Right, right.
and so that's why lumbar epidural did not survive because the drug used to go linear and never used to go into the roots. Yes,
So the shoulders are coming.
shoulders are
can
coming.
Maybe
yeah.
pull down.
Yes, yes. So, shoulders को थोड़ा नीचे करना. Shoulder को नीचे करो भाई. सब खड़े हो जाते हो देखने. हाँ. ठीक है. इस वाले को भी करना पड़ेगा.
So the question is, how long will the block be effective?
See, generally in our experience, because this is a not non-weight bearing area of the spine. So generally in our case, I hardly repeat these injections. Only thing is that you have to have a good follow-up. So some like lifestyle modifications and exercises later on. नहीं आ रहा shoulder. Shoulder बीच में आ रहा है भाई. ये क्या है? Shoulder है? हाथ है? क्या आ रहा है बीच में? ठीक है चलो एपी कर दो फिर. इसको ऊपर करोगे ना. हाँ.
He doesn't use anything else.
So as I said, because this is non-weight bearing area of the spine, so if you take care of the radicular symptoms and अभी भी नहीं आ रहा. थोड़ा और ऊपर करना.
So what is the logic with some people who use bupivacaine along with solomedrol?
Bupivacaine?
Yeah, or any other anesthetic agents? Sir?
No, solomedrol obviously we don't use here.
Okay.
Solomedrol is a soluble which we give IV and here we use a depomedrol. So depo preparation generally remain at that site for a
No,
longer period.
No, my question is depomedrol with some lignocaine or something.
Well, that is only because initially, when you put a depomedrol on the nerve root, which is already inflamed, there is an aggravation of pain.
Okay.
So we also give about very low volume of xylocaine, lignocaine without preservative, along with our solution. That's only to subset the pain which arises because of the direct installation of drug on the nerve.
Right.
AP कर दो, छोड़ दो. छोड़ दो, AP कर लो, छोड़ दो. Sorry, we couldn't, because of the shoulder, we couldn't show
No
you.
problem.
Yeah,
Can we define the entry point again, sir?
yeah, I will. I will show you the lateral once we have put the drug. See the entry point, थोड़ा सा नीचे ले जाओ, हल्का सा नीचे.
So question is about triamcinolone. Can we use
Triamcinolone, yes, we use triamcinolone. It's your choice. So now you see the entry point on the fluoroscope. We are midline. This is classical intralaminer. You can direct the needle little on the left side also.
we injecting depomedrol also now?
No, I'm just identifying the space,
Okay.
not yet in the space. Because it's a disease patient, the ligamentum flavum is very thick.
Yes. I think that makes the procedure more difficult for beginners because
So now you see my syringe is going easily. But it was a very hard, almost like a bony consistency ligamentum flavum. So here you have to use all your experience so that you don't go beyond this. So there is a loss of resistance, and now you see the direction of the needle, it is directed cephalad, and I'll have a good spread of dye. This is more on the right side.
this is saline, sir, which you
No, this is dye. So I'm still not happy with the spread of the dye. Some more dye. So I'll use a catheter now.
This is which gauge catheter, sir?
So
What
this
is
is like a, for a 18 gauge, we have a 20 gauge catheter. You go up to 15 mark.
Okay.
And again the dye, you see the spread. Yes, it is going. You can see the spread of the dye.
Yes, sir. Yes, sir.
Some more saline, please, saline.
To repeat a shot, I think, sir, we can repeat a shot. Yeah.
Yeah, now I'm getting a good spread of the dye, both the direction, both the sides. So even if you are at C6, C7 or even C71, which is a very wide space, you will see the spread of drug on both the sides.
Right,
Spread
sir.
of drug.
Very nice.
Yeah.
So you have given the dopamidrol?
Now I'm giving.
Okay, sir.
Now
Okay.
I'm giving. I will
So you give, say, you are giving 80 mg, sir, again?
80 mg, yeah.
Okay, 80 mg 2 ml.
Yeah, I'm just repositioning the catheter so that the spread is good all around.
Okay, sir, we'll go to OT4. They are
Yeah,
waiting for us.
please,
Thank you
please.
so much.
Thank
It's been
you.
excellent demonstration.
Thanks a lot. Thank you so much.
Okay, sir. We shift to OT4. Dr. Ashish, we are there with you.
Yeah, hi Deepak.
Yes.
So we have already cannulated. You can see foramen ovale, and we are in the middle part of the foramen.
Yes,
Now that is exactly the place where V2 is.
right.
So for V2, we have to be in the middle. So we are comfortably placed there. Show the lateral, please.
So you went in with the submental view and then you took a lateral, is it?
Yes.
Okay.
So for around 6 centimeters
Yes.
or 7 centimeters, you can go submental and then shift to the lateral. Lateral kar dijiye.
Ashish, in V2, the target point on lateral will be how much different from the petrous and the.
So we are sir below the clivus about 1 to 2 millimeters.
Okay.
But sir, the best way is to have the stimulation where you get the maximum stimulation, and that is why we are stimulating. Shoot, please. Okay, here we are at the clivus. Can you appreciate?
Yes, yes, we can see.
So again, I'll draw attention of the audience. See, we are in the posterior part of the hard palate. We are at the junction of the clivus and the petrous on lateral, and on AP, again, you can very clearly see the H So the H is maxillary sinus and molar, and on the lateral side is the mandible, and then you have the petrous and the joint, and just above it. So can we give the stimulation now? The current. Yeah, thermal RF 75. कम कर दीजिए.
So you have done the stimulation parts?
Yes, yes, we have done both sensory and motor stimulation. 60 seconds.
And motor stimulation you did at 2 hertz, so same thing as
The same.
same. Okay.
In fact, with 0.2 volts, he had a good amount of motor stimulation.
Okay. Okay.
Start, please.
But in V2, you wouldn't have found anything moving as V3. Motor stimulation in V2.
Yes, sir, that is mainly because the exposed tip is 5 millimeter. So that goes on to suggest that the lower part of the tip is somehow touching the motor component and the current is flowing there.
You will still have those jerks in V2 on a motor stimulation.
We had in this patient.
Were you not confused whether you were V3 or V2?
No, sir, in this patient, what happened is while we were giving analgesic, this patient has dozed off. So he is not cooperating with us as far as the sensory stimulus is concerned. Yeah. So we are going more by anatomy. टैकी है क्या? टैकी हो रहा है. Okay. 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 One lateral shot, please. One lateral shot, please. Okay. Please give the current. Yes, start. Okay. So, if there are any questions,
The patient has an airway placed or what?
yes, the patient has a nasal airway. He is dozed off.
Acha, he's been dosed off.
Yes, please. Even with 75 degrees centigrade, he is deep right now. He is not writhing in pain.
So, Dr. Ashish, you also suggest touching the bony edge and then going in, or you can straight away go in the foramen for beginners?
No, sir. If you are getting a good position, I do not want anything to hit anywhere other than going bang in. Yes. And also, sir, these patients are awake. When you are entering, they have pain. So it's better to complete that part as early as quickly as possible.
There's a slight imagination, short of imagination. Like if you see the inside of the oral mouth, then which anatomical structure would be overlying the foramen ovale?
So basically, it will be a little lateral to the base of the third molar.
Lateral means towards the buccinator side.
Yes, toward the mandible side. Towards the mandible side. So there is a gap between the mandible and the maxilla. Base of molar is medial, and the coronal part of the mandible is lateral. So in between maxilla and mandible.
So I think surgeons, maxillofacial surgeons who are removing the wisdom tooth, they may be a little more careful now.
No, sir, this is quite deep. I'll show, no, there is some confusion, sir, there. You see, the foramen ovale, the molar is here.
Molar is here.
Here, and the ovale is here.
How many centimeters?
So this is very easily 5-6 centimeters inside. They cannot damage.
And so what is lying in between the two? Between the ovale and the wisdom tooth, what anatomical structure lie there?
No, here you mean to say? Yeah, there's be just skull bones and you're lateral to the maxillary sinus. So
Okay.
this is the maxilla and this area is the sinus.
Will
So
it be the infratemporal fossa? No,
yeah, this area is the infratemporal fossa.
you're traversing through the infratemporal fossa.
Yes. So sir, for third nerve V3 schwannomas, generally we take the infratemporal approach, no? So that is the same route through which you are going. हो गया ना? Can we remove? दो shots हो गए. Okay.
Very nice, Dr. Ashish. Very nice, I would say.
Thank you, sir. So if there are any questions related to this, I think we have finished all the cases of trigeminal. So if there are any questions,
No, I think it is very good. We can, when you have your talk, then we can discuss further.
yeah. Also, Deepak,
Yes.
another thing that I want to show is, you see the C2 here, odontoid.
Yes.
Flip to AP. AP दिखाओ. So if you have any confusion,
Yes.
this is almost the odontoid shape you get here. The
Okay.
mandible, the shape, this I consider as the odontoid and this is the body,
Right.
and here is the maxilla. So
Right.
this appears more like an odontoid shaped
Understood.
structure.
Understood.
Actually,
Yeah.
it's the coronoid process.
Yeah, that's the coronoid process, sir. This is the condyle joining this is the temporomandibular joint. The joint is very well seen.
Right.
Yeah, so inferior to that, you have the petrous and just above the petrous. So it is called the SPT line, superficial petrous temporal line. So this is the SPT line. So you have to go above the SPT line.
Can you please repeat that point?
Okay.
SPT?
Yeah, so you have the petrous temporal line. So the ovale is just cranial to the petrous temporal line. So the center, the H ka jo horizontal wing hai, that is formed by the petrous temporal. So it is just above that.
Any questions from the audience? Anything? Ashish, the question is, do you put any medication after this RFA there inside?
No, we don't put anything here, but after RFA, antibiotic, analgesic, and we do not stop carbamazepine or oxcarbamazepine immediately. We start reducing the dose and gradually we sort of taper it off.
Okay. Thank you so much, Ashish. Excellent.
Thanks, Deepak.
So we shift to OT5. OT5, the patient has not come in yet. OT5, Dr. Surya is there, na? Not regularly. We have started 40 major cases, not these things. 40 major cases like CP angle, all those things. We are planning to do 8 to 10 cases now, half a day, 2 OTs. OT5, who's there?
Sir, Surya this side will be presenting the stellate ganglion block case from
Here.
OT4.
Acha, so,
In a while.
where's the patient?
Sir, we are shifting out the trigeminal neuralgia patient.
In
And that-
OT4, you have the stellate ganglia.
Yes, sir. OT4 is stellate ganglion block.
And OT5?
is root
Why is
block.
5 empty?
So we are shifting the patient.
So you can have the cases presented, at least we can have a discussion. Is
So we are shifting the patient of OT5 to OT5. So meanwhile, Vishal is presenting that case.
let them present the case.
Should I start?
OT5.
Good morning.
Yes.
This is OT5 fifth case. Is a 43-year-old male with complaint of pain in lower back and radiating to left side leg and foot since last 8 months, with paresthesias and increase on prolonged standing. There's incomplete remission of pain on medication. On examination, patient having no deficits and detail 2+. The SLRT was positive on left side at 30°, and osmotic disability index is mild. The MRI was done showing 2-level PIVD, L4, L5 and L5S1. There's a axial imaging showing there's a 4L5 PIVD with left side neural foramen narrowing.
What is the plan of management?
So the plan is for left side root block at L5, transforaminal.
PIPD, this does not have significant, but question is if the pain is relieved, most of them may get away with physiotherapy. But stay with after 2 surgery का तो number this का तो number ही नहीं आता for surgery. हाँ, different number.
Apart from that, just pain.
हाँ, you don't need.
हमारे टाइम में इतना डरते थे हम लोग कि in exams also they used to ask that okay after 4 months patients coming with a foot drop because it's like putting
Hello.
Yes.
Hello, sir. We have our 4th case in OT4.
हाँ, please present. मैंने shift to OT4. Shift to OT4. Yes, Menas.
Yes, sir. Our 4th case in OT4 is patient Narsimurthy. He is a case of
Can we have the PPT?
yes, sir.
We are not able to see.
Is it seen now, sir?
No. Now it is visible. Okay.
This is patient Narsimurthy, sir. He's our 4th patient in OT4. He is a young 27-year-old male who complains of excessive sweating since childhood in bilateral palms and soles. Patient does not have any other complaints and he has been planned for stellate ganglion block, sir. This is a clinical photograph of this patient. We can see he has excessive sweating even at normal temperature. He's planned for bilateral stellate ganglion block, sir.
stellate ganglion. Can you tell us the anatomy which it is formed with the union of
Hello, Dr. Ashish sir, you are
We
connected,
just
sir.
thought why it's not that fact we wanted to. do
45.
that stellate ganglion. That's the only thing. Yes, yes, we. Much more.
थोड़ा सा आप ना हाथ ऐसे रख लें अपने,
Why not let it?
ये अभी भी थोड़ा सा टेढ़ा है
So do we have
मेरे तरफ लेके,
who's the faculty here?
मेरे तरफ लेके आइए. Deepak, are you there with me?
Uh,
Deepak?
yes, sir.
Hi, Deepak. So we are here with this next patient,
Right,
and this gentleman has disc at 2 levels,
right, Ashish.
L45 and L5S1. So my plan for him is not just I'll demonstrate L5 as well as I'll try a S1 root block also.
So you will do this transforaminal on the left side.
On the left side, both would be transforaminal, but the traditional way, not the way that I showed
Okay.
in the morning.
Understood.
Abhi थोड़ी देर पहले.
And would you add a medial branch block also to this?
No. Siam, please. Can I get a K wire? ले So basically the difference between a diagnostic and a therapeutic block is just the amount of drug and where you are depositing the drug.
Okay.
So for example, if you are doing a L5 root block, then obviously you are just putting it at L5 and very limited amount that it does not spill over to S1 or L4.
Right.
If it is a diagnostic block, also you don't want it to go into the epidural space or facet joint. So diagnostic is a diagnostic technique to confirm the source of the pain. ऐसे tilt कर लीजिए. So here my intention is not diagnostic, it is therapeutic. So that is why I am not restricting to L5. I'll try and do a S1 as well.
Okay.
हाँ, दिखाइए. सिस्टर एक्सरे ले रहे हैं. शूट प्लीज. मार्किंग पेन देंगे मुझे. Shoot, please. Shoot, please. Shoot, please. Shoot, please.
So you're trying to see for the S1.
S1. Shoot, please. Shoot, please. Local, please. अब इसको थोड़ा ऐसा मेरे तरफ टिल्ट कर दीजिए. सर, स्कॉटी डॉग दे दीजिए. हाँ, और टिल्ट कीजिए. हाँ, 20 डिग्रीज एटलीस्ट. हाँ, ठीक है. ओके. शूट नाउ. ओके, लोकल प्लीज. शूट. सॉरी, मैंने कर लिया, क्लीन कर लिया. थैंक यू. Local, please. So I hope you can appreciate the Scotty dog.
Yes, yes, yes.
Okay, so the eye of the pedicle, the transverse process, the ear, which is the superior articular process, the lamina spinous process of the body, the leg will come as the inferior articular process. This is the facet joint. So facet joint, foramen, pedicle, superior articular process, lamina spinous process here. Local, please. Local. हाँ, thanks. हाँ, ठीक. ये थोड़ा हाइट बढ़ाएंगे क्या इसका?
How much angulation you have given to the C-arm?
या कितना एंगल है? 20 degrees.
Okay.
थोड़ा ऊपर करना. हाँ, और कर ले, और कर ले. ओके. एक सुई पता चलेगी आपको. बस 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 हो गया. बस सुन्न कर रहा हूं बेटा. एक और नीडल मिलेगी मुझे. ब्रदर, कैन आई गेट अ नीडल? नो नो, जस्ट अ सिंपल नीडल. नहीं, पतली वाली. And I'll need 2 spinal needles. 22, 21 दोनों में से कोई भी एक चलेगी. हाँ. एक और नीडल आपको पता चलेगी, एक सुई और पता चलेगी. बस बस हो गया, हो गया. शूट करिए प्लीज. So if you will appreciate, my one tip is very near to the superior articular process. अब AP कर दीजिए, AP कर लीजिए, कर लीजिए, बस shoot करिए. And the other is very near to the S1 foramen. Lateral नहीं है, medial पे है, लेकिन ये छोटी नीडल है. ये अगर हम ऐसे चले जाएंगे तो बस 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 शून्य कर रहे हैं. शूट प्लीज. ये है फोरामेन पे. ठीक है, चलो गुड. ड्रेपिंग प्लीज, क्लीनिंग प्लीज.
So you have put in local at two places.
Yes, because again L5 and S1.
Right. Understood.
Yeah. So the S1 route is going to come like this, and it is going to exit here, either say, and L5 will come here. So we'll give specific blocks to each.
Okay.
हाँ कर दो ना please.
Can you please repeat, like, how did you localize L5 entry point?
Oh yeah, हाँ. So तो वो मुझे Scotty dog दिखाया क्या? Sir, can you see this? This is the Scotty dog.
Yes.
So in the Scotty dog, this is the foramen that you can see.
We need to zoom in actually.
Zoom करेंगे इसको?
उसको main screen कर दें.
उसको main screen कर सकते हैं, PIP को.
किया क्या? Okay.
नहीं, हाँ आप किया.
हाँ.
That's it.
So this is the foramen here, sir, of L5S1
The left side, is it?
on the left side. Okay. So this is the foramen. So this is the superior articular process.
Okay.
The root is going to come like this. So here my intention is to give a supraneural block.
Where is the pedicle?
So this is the pedicle here. This is the eye of the Scotty dog. ठीक है? और फिर ये nose आएगी. तो हम इस point को target करेंगे sir. And the root is going to come show like this.
That is the exiting route, no?
That would be the exiting route for that would be the L5 exiting route. So because the patient has a L4-5 disc causing L5 root compression, so I am giving one block here, and he also has a L5-S1 disc, so I am blocking S1. Drape, please.
We'll just go to OT4 and come back. Ashish,
Yeah.
shift to OT4. So Dr. Vaishnavi, are you there?
Hello, sir. Good morning.
Good
I
morning.
hope I'm audible.
Yes, very clear.
So, as you were asking about the anatomy of the stellate ganglion, it is formed by the inferior cervical ganglion, that is C7 and T1, and some amount of contribution from T2 as well.
Okay. One of the question Dr. Milind was asking was because he's got hyperhidrosis.
Yes, sir.
Wouldn't be a sympathetic block be more useful in this? Sympathetic chain block.
So actually, there are multiple indications for stellate ganglion block because majorly it is a sympathetic thing.
Right.
So one of the indication is hyperhidrosis.
Okay.
But the most common indication that we use sympathetic blocks is mainly the vascular causes, that is ischemic causes, especially acute vascular ischemia of the upper limb.
Right.
And we can use it for CRPS, which is another most common indication.
What is that? TRPS?
CRPS, chronic regional pain syndrome, either type 1 or type 2, that is with or without injury. I'll be discussing about the CRPS in detail tomorrow, actually, after when we discuss about the brachial plexus injuries.
The doubt was that the hyperhidrosis in the lower limbs, the feet, how is that going to benefit by this?
Because the patient gives specific history of when the stress is more, the hyperhidrosis is more. That itself says that when the sympathetic system is getting activated, he is having more of sweating, and hyperhidrosis, for hyperhidrosis, sympathectomy is one of the indication.
No, like stellate ganglion has got
The sympathetic ganglion,
It's
it
a
is for
sympathetic
the
ganglion.
upper cervical ganglion is a sympathetic ganglion.
It's a sympathetic ganglion. But Dr. Vaishnavi, we used to do endoscopic thoracic sympathectomies for hyperhidrosis and also put stimulators endoscopically for hyperhidrosis.
Yes, sir, that is a definitive therapy and this is a diagnostic thing. We will see how far it is going to help before going for an invasive procedure.
the lower feet, the feet also, the
Yes, sir, patient
it's
is
coming
having.
through the stellate. Is it coming through the stellate ganglion only? The sympathetic supply to the feet?
No, sympathetic supply to the feet is obviously from the lumbar plexus,
So that's
lumbar
what my question
sympathetic
is,
plexus.
that patient has got hyperhidrosis of all the four limbs, isn't it?
Yes, yes.
So then why are you doing only stellate? You should do a lumbar as well, no?
Ideally, yes, sir. Lumbar sympathectomy.
So it's only for the upper limbs that it is going to be beneficial.
Yes,
right?
yes. గాలాడుతుందా అండి? Are you able to breathe? Yes. Don't worry. We are just covering your eyes.
Post aneurysm vasospasm we are doing routinely here at AIIMS. Straight ganglion block.
Any vasospasm, you don't
Yes.
intracranial
Intracranial vasospasm.
getting benefited by
Excellent results.
And in our place, we are using stellate ganglion blocks, especially RF ablations, not blocks. Stellate ganglion RF ablations we are doing for VT storms. Even after the patient is having a defibrillator in situ, if the patient is having
Interesting.
continuous shocks, even after the defibrillator in situ, we are doing stellate ganglion RF ablations. If the patient is having a preserved EF, we are doing unilateral. If the patient is having a low EF, then we are doing only unilateral stellate ganglion RFs to decrease the number of shocks, preserving the EF. Someone give me the pro, please.
So Vaishnavi, we would request you to hold on. We'll just go to the other OT and come back to you.
Sure, sir.
Okay. Shift to OT4.
Yes.
OT5. Dr. Ashish.
Yeah, hi.
Hi. We are there with you. Are you ready?
Yeah, I'm ready. So I'll first try. Bus.
Rashish, the landmarks were overlying the foramina. and
Shoot.
The levels.
I'm sorry, sir.
The landmarks of entry,
Yeah.
they were corresponding vertically down, like they were just above the foramina level.
No, at S1, yes, but for L5, because it's a Scotty dog, we are far lateral.
Okay.
Yeah. अब आप इसको टिल्ट करिए 20 डिग्री. हाँ, ठीक है. I have created a bevel on the needle. Shoot, please.
Yes, we can see.
ज्यादा हो गया है क्या? नहीं, लेकिन अच्छा नहीं दिख. या तो एंगल थोड़ा ज्यादा करो. देखो, पहले ज्यादा अच्छा दिख रहा था. हाँ, अभी शूट करिए. शूट करिए. हाँ, अभी करिए. बेटर और टिल्ट करिए. हाँ, अब शूट करिए. एक्सेलेंट, ठीक. शूट प्लीज. ऐसा क्यों? हमने जब मार्क किया था. इसको कम टिल्ट करिए जरा. वहां देखिए, वो ज्यादा अच्छा दिख रहा था. ओके, शूट प्लीज. थोड़ा और कम करिए टिल्ट. हाँ, अभी शूट करिए. शूट. बस. लोकल लेके रखना प्लीज. शूट. यस, मुझे लोकल दीजिएगा. Simple, like ligno के. दीजिए. Yeah, that should be okay. Shoot, please. Shoot, please. एक सुन की सुई पता चलेगी. बस 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 बस. शूट करना. ओके. शूट प्लीज. शूट प्लीज. शूट.
Yes, now it looks okay.
या एपी व्यू प्लीज. थोड़ा एपी कर दीजिए. बस इतने ही रखिए. अभी शूट करिए. टिल्ट मत खत्म करना. ओके, सो दिस इज अ गुड लोकेशन. हाँ
Yes.
हाँ हाँ. अभी कम हो जाएगा. शूट करिए. शूट करिए. ओके. अब मेरे को लैटरल दिखाइए. So always confirm in 2 dimension before you inject the dye,
Right.
because once if the dye is at the wrong place, Deepak,
Yes.
then it becomes all black. You won't be able to see the needle tip
Okay.
till it, either you wash it off or, so it is better to confirm AP lateral and then. Okay. हाँ, अपन lateral देख लेते हैं, या आप कर लीजिए, सीधा कर लीजिए. नहीं, ये अभी और टेढ़ा नहीं हो गया. ऐसा करो, ऐसा. हाँ, अब नीचे लेके आ जाइए. नीचे ले आइए. या प्लीज शूट. वो उधर नहीं गया, उधर नहीं आया. हाँ, शूट करिए. शूट प्लीज.
X. हाँ.
Yeah, because that hole is a little. ये तो हम lateral से जा रहे हैं, because the ala, I'll show it to there why it is a little more challenging. So I think this can go a little bit more inside. Shoot.
In lateral view, what should be the tip point? At
Yeah,
the-
you can see the tip point,
Yes.
Deepak.
Yes.
Huh. So my S1 is a little bit more inside, so I am pulling it out a little bit. Shoot, please.
L5 seems so now touching the posterior border of the vertebra.
Yeah, so that I'm not going to change. Shoot, please. Yeah, okay. Now AP. Die, please.
So both are in the center somewhere now in the foramen. Is that what you're wanting in the lateral view?
Yeah, so in the lateral view, basically in the foramen at L5 and in the epidural space at S1.
Right.
Tilt कर लीजिए please. हाँ, craniocaudal बस. Shoot करिए. So this is good, this is good. Let's try first this one. So always inject just 0.1 or 0.2 cc's so that shoot. Okay, you can start seeing. I'll put more now. Shoot. Okay. Guys, you see the root?
Yes, yes, very
Okay,
nice.
So
very
that's one done. And now I'll try and confirm with this. Shoot, please. Okay, I'll go a little deep. Bus. Shoot, please. एक काम करते हैं. First of all, let me give a block at L5 since
But-
Orkin.
This is also going up. If you see,
Yeah, it is. It is. It is going through the foramen, but
yes,
still, Deepak, I'm not very happy with it.
हाँ, वो initial वाला थोड़ा सा spread हो गया. The
हाँ.
second one has gone along.
Yes. This is preservative free. नहीं, I want preservative free Sensorcaine, Bupivacaine, वो ही जैसे पहले लिया था अपन ने, same thing. हाँ. So, Tushar sir,
Yes, yes.
so you see now this is the exiting route for L5S1. So this is the L5 route. So if you have a L5S1 disc, this is the target, this is the nerve route.
Yeah.
ये तो पहले ही बाहर निकल चुकी है sir. So if you have a disc prolapse, this is. But if there is an extra foraminal disc, then it will touch here. जी sir. दे रहे हैं Sensorcaine and
So what combination you are using?
again same thing, Deepak. I prefer Bupivacaine preservative free, diluted 1.5 ml,
Right.
and again
4 mg Dexa.
Dexa. Again, as I told you, bus.
So how long does the pain relief last with this combination?
Yeah. Shoot, please. So that looks okay. Steroid. Okay. So when I explain to the patient, Deepak, it's rule of 35 for me. So 35% of the patients will have a failure of the procedure.
Right.
Another 35% of patients will have, or 30% patients will have relief, but it will be short term from 1 to 3 weeks.
Okay.
And only the rest of the 33% would have a long term relief. So if you look at the sports trial, the sport trial says that around 40-50% of the patients would be able to avoid surgery.
Right. But those who fail within the first 3 weeks, initially improve, you repeat?
Until unless you have not given a proper block. Otherwise, if the block is proper and if he is not responding, that means he is not responding, he will not respond with the second as well.
No, those who have responded and then have a recurrence after 3
Yeah, you can repeat.
Okay.
Shoot, please. So that route is gone. So I'm pulling out this needle. Okay. So this is okay. Now give me stillet दीजिएगा.
In pathology other than? That's a, Ashish, the question is in case of pathology other than disc, some other metastasis or something else, will it work?
So this will work only if there is radiculitis. If you are treating radiculitis, that could be secondary to a disc prolapse, it could be secondary to facetal arthropathy, it could be secondary to any other inflammatory process, but the best results are for disc. Then you have level 1 evidence for disc, and for facetal arthropathy, lateral recess, you have level 2 and level 3 evidence that it is effective.
Okay. Okay.
Shoot, please. Die dena. Die. Yeah, die. Die. Yeah. Sure, na? हाँ. Shoot करिए. Okay. So this root is going up.
Yes.
Yeah. थोड़ा सा. हाँ, shoot करिए. Okay. दीजिएगा. वो sensorcaine and steroid. Bupivacaine and steroid. मिक्स कर सकते हैं आप, बट आई प्रेफर सेपरेट.
1.5 ml of bupivacaine.
Yes, sir. Diluted 0.25% bupivacaine. You can also use ropivacaine 0.2 or 0.5%. There are people using ropivacaine also. ये sensorcaine है? Okay.
So do you believe that radiculitis is the only concern? What about the compression of the root?
Sir, it is not going to in any way help the compression. It is only decreasing the phospholipase. PLA2 को कम करेगा. So it is only inflammation that you are doing this for. Compression part, the body is going to deal with it with time. Steroid.
Multiple procedures. The question is from the audience.
Yes, sir.
Multiple root blocks.
Yes.
And what is your experience like?
No. The question is, after multiple root blocks, does it make a difference to endoscopic discectomy or discectomy?
Oh, okay. That's a good question. See, when you are using depot, एक shot ले लीजिएगा. When you are using depot material, oh, beautiful. You see the root?
Yes.
हाँ, so it's gone. बढ़िया आ रहा है. तो ये traversing route है sir for L5S1.
Right.
So S1 का ये चलो, okay, done. हो गया भाई. So for endoscopic disc, there are two things that we are aware. One is when you are using depot preparation, you see those particles inside, and there is some adhesion which is more than a nascent case. And second is there is a slight increase in the rate of infection after any form of discectomy, not just endoscopic. After the block, especially repeated blocks, the risk of infection is higher.
Okay. ठीक है आशीष. Thank you so much. We have to shift to the other OT. Thank you again.
Thank you so much, Deepak.
Thank you.
Okay, Dr. Vaishnavi, sorry to keep you waiting.
That's fine, sir. That is totally okay.
Now we are totally with you. Please explain.
I hope my screen is visible here.
Yes. Can you increase the brightness of the ultrasound?
Sir, I tried. This is the maximum I can actually get.
Okay.
The gain you can increase here. So the probe I am using right now is a low frequency probe.
Right.
Sorry, high frequency probe. But only the footprint is a small footprint hockey stick probe.
What is the range of the frequency?
This is 12, sir. Actually, it is like different company produce different. But what we use is usually 14 to 12 to 5 usually. So this high frequency probe with a smaller footprint. So first try to be in the midline and see the airway. So what structure you are seeing here is the airway.
Right.
Usually it is a cricoid cartilage that we see here.
Yes.
Okay, so slowly try to come laterally.
Right.
And the structure that you are able to see here is a thyroid gland.
Right.
And
Somebody point on the screen.
That is the
this is the gland here.
medial to the carotid.
This is the airway you're seeing here, and this is the cartilage, which is very visible, the line.
No, we can't see.
No, I.
Pointing.
Okay.
Good.
Sorry, sir, you're not able to.
Not Deepak is
I will
helping by
point it
pointing
out,
here.
Vaishnavi. There's no problem. So this is the airway. This is the midline. This is the airway. So you see it as a white line. The white lines are the most important. This is the airway. Go lateral. Vaishnavi shows the thyroid.
This is the thyroid.
So this is the thyroid like a liver or anything. You see this.
The echo texture is somewhat like liver, but not that very coarse. It is little finer
And
because the
then-
gland is very smooth.
This is the
This is the
carotid.
border of the thyroid. And now,
What is this?
Carotid.
this is now the compressible structure is IJV here,
This is the IJV. This is the carotid.
and this is the carotid artery here. Now we are coming more laterally. Now our point of interest is to find out whether we are at C6 or not. So we need to hunt for the C6 transverse process, that is a Chesagnance tubercle, which looks like ears of rabbit. So keep looking for it up and down.
Looks like
Ear of rabbit.
ear of rabbit.
Rabbit ear.
Okay.
So here we can see one small thing coming and going. So keep looking in this particular part of the screen.
Right.
So now it has gone. Now it has appeared.
Yes.
Now it has gone. Now it
Right.
has appeared. Now it has gone.
Right.
So this confirms that we are at C6.
So this white line which you are seeing.
The black line. So now again I'll come again
Okay,
from the
okay.
beginning.
Right.
So this is the midline.
Yes.
Now I'm lateral.
Yes.
More lateral. This is
Yes.
the carotid.
Right.
Now I'm coming more laterally.
Right.
Now I'm trying to visualize the AT, anterior tubercle. Now,
This one.
yes sir, internal jugular I have compressed. This is the internal jugular. Okay sir. So now, this is the Chesagnance tubercle.
Right. Right.
Okay.
I'll just show
So-
it to you.
Please show.
So now, this is the longus colli muscle.
Can you go to
Just
this?
hold
Is
on,
this?
Dr.
This is.
Deepak
This is the
Okay. What is the landmark? Like lateral to the IJV.
lateral to carotid and IJV. There is this. You can see the.
This is the
tubercle.
IJV. I have compressed it.
This is the IJV.
Right. And below that, what is the?
Carotid is
What
there.
is lateral to the carotid? This where
This
your
would be
hand
the. This is all the muscle mass.
So this is a sternocleido here, sir.
This
This
is
is the
sternocleido.
IJV, carotid, thyroid. This is the longus colli muscle,
These are the strap muscles. This
strap
is the-
muscles,
this
and
is
this
the-
is the target, our target. The more lower you can go, so the literature says previous.
target. I'm not clear, Vaishnavi. I have to go.
So I'm just telling about the review of literature, sir, here.
Ah.
So previously what they used to do is when the RF and all is not there, so we used to just dump the drug near at the level of the Chesagnance here, just below the carotid.
Okay.
But now, because C6 doesn't contribute to the inferior cervical ganglion, that is the stellate ganglion, it is a C7.
Right.
So previously what people used to do is just dump the drug here, more volume like 20 to 25 ml, and make the patient sit upright, thinking that it will track down and will have the effect. So now that we have advanced techniques and all, so now we don't want at the Chesagnance. So this is the Chesagnance here. Now
Chesagnance. CHASS.
this one,
Chesagnance.
C6.
Dr. Vaishnavi, you have a resident.
C6 tubercle.
If you have a resident now, he can point it out on the.
So you are able to see the ultrasound?
Yes, we are able
He
to.
did so well.
We are able to. Can you freeze the screen and point with the instrument?
Your reading and our.
Freeze the
reading is
screen.
different.
Because even I'm not sure if I'm telling them the right thing.
Screen has to be shown. Ultrasound. Somebody has to point. I think this is.
So this is what,
Rather than transmitting the ultrasound image directly to us, somebody can focus the camera on the ultrasound screen. And then you will be able to show to us. Dr. Shiva, you can help. The ultrasound. Yeah. Now we can focus and somebody can show us the exact location of C6 tubercle.
so again I'm coming, this is the midline,
Right,
Right.
this is the thyroid,
right.
this is the esophagus,
Eastham is
Ah,
lateral.
that-
Yeah,
yeah.
because the rays were going like this, sir, towards
Huh.
the midline.
Don't confuse them, Vaishnavi, just to do the
Okay, sir.
thyroid.
This is the thyroid. This is the carotid.
Right,
I'm relieving the pressure. That is the IJV.
right.
Right.
So now I have come more laterally,
Hmm.
and now I'm trying to look for the chest against tubercle. Now that is the tubercle. That black horn kind of thing that you're seeing.
Yeah.
This.
Okay, this is the one.
Okay.
Right.
Now we will just follow it down.
Okay.
Yes, sir.
We know that this is C6 only and not any other.
The tubercle is specific only for C6, sir.
Have you tried using the C-arm?
Yes, sir. Yes, sir, I did that.
That will be less operator dependent actually.
But
Even to locate
the
C7
problem-
on C-arm would be also not very easy.
because the first rib, and when we go and hit the, then we need to go hit the transverse process between the transverse process and the vertebral body as close to the body as possible. And the problem is vertebral artery, sir, and we will not be able to see the carotid and vasculature.
Right.
Here we get anterior thyroid artery as well.
Right.
It's a highly vascular structure area, so we would rather do with ultrasound.
Right.
Okay, so now once we have seen the chest
Yes,
against,
yes, yes.
so now come more little down till it is not visible.
Okay,
And then again come to the midline where you see carotid again,
yes,
and now longus coeli again. And now the place between the carotid,
Hmm.
and the longus coeli, this will be the target usually while doing RF ablations.
so we have to go inferior to the level. to the
Inferior
level.
to C6.
So at the level of C7, let's
Yes,
say.
C7.
And does it appear hyper equal?
Yes, sir. Yes, sir. Now you can see, I think.
Yes, yes.
And it's just behind the carotid.
Yes, it just beneath the carotid, and to avoid the injury, you can always compress the IJV. Now I have released the pressure. Now I have compressed it.
Yes, yes. We can
And-
see that.
So just go, and this is the longus coeli. Here you are seeing, what you are seeing is the clavicle, and here is the muscle. This is the artery. Just this is your target.
Okay.
Local.
What are you going to give now?
Sir, I am going to give mixture of 0.2 Ropin. Hand rub with the gauze piece, please.
Okay.
So because I need to give volume here, I am choosing more cardiac stable drug. So 0.2 ropivacaine I am using, along with some amount of steroid so that it makes it longer acting. That's all.
Right.
చిన్న సూది ఈయన తెలుగు తెలుసు అంటేనా అంతే అండి ఓకే You can see my local needle as well.
Yes,
I pierce the sternocleid also.
yes,
That's my local spreading over there.
yes.
River pressure needle. That major needle, bigger one. So for making, for the beginners, it is make it easy. I am using a Stemoplex needle, which is having serrations on it, and which it makes the ultrasonic thing very visible. So Stemoplex.
What is the name of the needle?
Stemoplex, actually it is a stimulator, Stemoplex needle.
Stimulator. Stemoplex.
Nopunda? I hope my needle also is visible.
We can see it.
Yeah. So
Let-
now I am,
Needle tip is not visible. Yes, now it
Yeah.
is.
so now I am parallel to the carotid. I'm trying to see the tip before advancing. So now it's like if I go here, I'll be hitting the carotid. So I'll go more angulated and try to lift it. If you have any doubt, we can always see by doing 3 techniques, that is by sliding. This is the sliding and gliding technique, what I'm doing with the
Ultrasound.
probe,
Right.
okay, without moving my needle. This is rotational movement that I'm trying to do. So here, now I will try to find my needle. No, it's not visible.
We also have ultrasound stations
See,
on day
this
3, so
is-
you can learn all this.
This is the needle. I hope my needle is visible now.
Yes, yes.
Now my needle tip is also reached the 6 o'clock position of the artery.
Right.
Instead of wasting the drug, what we can do is we can use saline. Please flush the saline to 2 ml. It is there. Here. Always aspirate. Aspirate. Negative for aspiration. I hope everyone are able to see the drug spread.
Yeah, we can see the black.
Stop. Now there we are going to give the drug that we have taken. The ultrasonic confirmation is the artery should always leave the bone and go away.
The artery should?
Leave the bone and go away, sir. That's what we say.
Artery should?
Leave the bone. The bone will be always here. The bone will be always here. So artery should,
leave the bone.
yeah, leave the bone and go away.
I mean, if you put in saline, the artery should separate.
Should
Yeah.
just go away.
Yeah. That is the good placement of the needle. So please flush. Aspirating, negative for aspiration. I hope everyone are
Yes,
able to see.
we can see.
Yeah.
Yeah. Then this is the place we give full drug. Stop. If you are not confident, then what you can do is you can always readjust the needle. In case now I am trying to readjust the needle here. This is only for the delegates to understand that we can readjust the needle anytime during the procedure. So I hope my needle is visible, the tip, including the tip.
Yes.
So again focus the artery. Again try to see the artery. Get to the skin. Don't come out of the skin so that the anesthesia is still preserved. Here don't go. Now again we can redirect it. Again I think my needle is visible here.
Yes.
So come. Yes, I'm there. This is the needle.
हाँ, PIP में patient
Okay.
भी डाल दे.
Mm.
अनुज,
Aspirate.
PIP में patient.
Negative.
Audio, video. हाँ.
Give
एक
the
ही
whole
कैमरा है क्या वहाँ पे?
thing. They've given, no? Fine. Hello, nurse. Ella unnaru? How are you? Now keep your head straight. Open your eyes. We will just give little head up.
What are we watching for?
Head. We are watching for meiosis, sir. Horner syndrome. Ptosis, meiosis, and anhidrosis. It is not present in all the patients actually, but that is the surest sign though. Open your eyes. We can, if we, the successful block actually shows anisocoria.
You can see anisocoria.
Not.
Okay.
Okay.
ठीक है वैष्णवी.
కన్ను బరువుగా ఉందా అండి? ఈ కన్ను కళ్ళు మూసుకోండి, గట్టిగా మూసుకోండి.
He understands, huh? What?
Yes sir, he is from south.
We'll refer him to you.
No eyes. Sorry sir. Open your eyes now. Yeah. Are you feeling some heaviness in this eye? Nothing. Okay.
డాక్టర్ వైష్ణవి
Yes sir.
ఒకసారి నీటిల్ చూపిస్తారా?
Sure sir.
Okay, Dr. Vaishnavi, thank
Yes,
you
sir.
so much.
Thank you sir.
నీటిల్
हाँ, needle दिखा दो. अच्छा, आप
So you wanted to see the
we
needle?
didn't understand what you said, ना?
Yeah.
ఒకసారి 1 minute. You can show the needle. Yep. It's just like a LPD.
No, sir, the sedations, if I don't know if the camera is nearby, I can show the sedations here
Yes.
because it is like both hyper and hypoechoic things are alternate.
What's
So
the
that
name of the needle?
it's like Stemoplex needle, sir.
Okay.
Yes.
Thank you so much.
Thank you, sir.
Can we shift to other OT? तो खाली है.
చూద్దాం కొద్దిసేపు అయిన తర్వాత యాక్షన్ వచ్చిన తర్వాత
वहाँ पे वो लगा हुआ था एलन टेबल लगा हुआ था सीधा टेबल किया हुआ
तो उससे क्या फर्क पड़ता है?
गया पता नहीं छोटा सा ही पार्ट होता है गाड़ी आती है पूरा बॉडी नहीं आना स्पष्टिटी आती है सिर्फ जिगरा जाएंगे हल्का ज़्यादा बन जाएगा
So who's presenting this case and what is this case?
डॉक्टर इला
नहीं नहीं प्रेसिडेंट होगा ना हमारा.
लाइक
राजेश सर माइक देना मैम को.
Hello.
तो
Hello.
ये बता दीजिए स्पष्टिटी है गिर जाएगा इसके लिए
Hello.
हेलो. हाँ सर, डॉक्टर राजेश मीना बोल रहा हूँ.
हाँ राजेश.
Sir, वो Dr. Ila will be presenting the case while the patient is shifting just now.
हाँ please. Dr. Ila, we are there with you.
Thank you, sir. Can you hear me, sir?
Yes.
Thank you, sir.
Dr. Ila, we missed you during inauguration.
I'm sorry, sir. I was in the OPD.
No issues, I know. Thank you so much. Thank you so much for coming.
Thank you for inviting me, sir. So it's made 20 units.
तो वो
हाँ,
इलेक्शन में दिखाने वाला था.
20 यहाँ तक होगा. That's fine. Perfect. Thank you. One by one.
बैक हो जाएगा तो ज़्यादा देर का काम
Rajesh, once the other OT is also free, we can keep the other case also ready for Botox so that the moment she finishes here, she can go to other OT and finish that also. And once this is over, we can call the third patient so that back to back she can finish the 3 cases.
सर लाइव रिलीव हो जाएगा ना रिलीव नहीं हो पाएगा इसलिए वो रिलीव का अरेंजमेंट वहीं से है
यहाँ मिल रहा है.
कैमरा कहाँ है ये ना
अभी तक हमें मिल रहा है, बंद हो जाए तो.
So we have this patient who
Yes, Ila.
So we have this patient who has cervical dystonia and also jaw closure dystonia. So the troublesome symptom for him at this point of time is the cervical dystonia. So as you can see, he has a neck tilt slightly towards the आप आराम से बैठ जाओ कुछ नहीं करना है जैसे गर्दन हो रहा है होने दीजिए. If you're able to appreciate the
Yes,
chin is
yes.
slightly pointing towards the left
Right.
and there is a mild tilt of the neck towards the right side.
Right.
And if you're able to appreciate the chin is also slightly tilted downwards like this anti-flexed. So that is not very obvious when he's just looking at us, but when he speaks something, it will become more prominent. I'll show you. आप आंख बंद करके 199 ऐसे उल्टी गिनती गिनी है. Now I'll turn the chair for you. You'll be able to see that we are able to see these creases in the neck.
Yes.
So that means that the neck गिनते जाइए sir. There is this tilt towards anteriorly and also the neck is slightly tilted this way. That's why we are able to see these creases.
Right.
On the other side, you don't see those many creases here because
Right.
the neck is tilted towards that side.
Correct,
But we
correct.
still do see that the neck is anti-flexed.
Right.
Basically, the head is anti-flexed on the neck. So there are 2 planes in the neck that we deal with. So one is the neck portion, which we call the anterocollis, and the head portion, we call it the anterocaput. So he has both an anterocollis as well as an anterocaput along with the laterocollis towards the right side. So we do that muscle targeting based on this pattern. When we talk about anterocollis, the main flexors of the neck are bilateral sternocleidomastoid and bilateral scalene. But when we see in this particular patient, there is also a significant component of anterocaput. So in such patients, there will be more benefit if you target the deeper muscles of the head, which is the longus capitis muscle. The muscle is actually inserted just on the anterior surface of the bodies of the vertebra, and it gets inserted at the skull base anteriorly. So we will be targeting that muscle just in, let me turn the chair like this. So just in front of the sternocleidomastoid. So you identify the sternocleidomastoid by asking the patient to turn towards the other side. उस तरफ देखिए, मेरे हाथ को धक्का देखिए सर, नहीं, देखो इस तरफ गर्दन को घुमाना है, घुमाइए. So we are able to see the sternocleidomastoid
Yes,
palpable
yes, we
here.
can see. Yes.
And just this is the mastoid process where the sternocleidomastoid is inserted. And just in front of the sternocleidomastoid, if you go perpendicularly inwards, you will hit the longus capitis muscle.
Okay.
And I will do that under EMG guidance, and you can hear the firing of the muscles, and we can demonstrate that. I'll just clean the neck and then we'll start the process. Spirits wrapped. So I have this handheld EMG machine. We'll put the silver chloride electrodes. अगर आपको कैमरा में दिखाने के लिए ग्लव्स चाहिए तो I can. So we are going to inject the bilateral sternocleidomastoid, scalene, longus capitis, and also the platysma. So the platysma muscle is a superficial muscle in the just below the jaw, and it gets inserted into the subcutaneous tissue in the anterior surface of the neck.
Why bilateral?
So-
Because his tilt is on one side.
So that there is a mild tilt towards the right, so we
Yeah.
will be dosing it slightly more on the right side.
Okay.
But because the flexion, the anterior flexion, it happens because of contraction, simultaneous contraction of both side muscles. But in this case, because there is a mild tilt towards the right, I will be giving a slightly higher dose in the right longus capitis, which will be 20 units on the right and 10 units on the left. Syringe उसके पास है.
Yes. So bilateral sternocleidomastoid, bilateral deep muscles, and bilateral platysma. That's what your plan is?
Yes, yes, sir. And bilateral scalene also.
Your scaliness. How long does the effect last?
So the effect lasts for up to 12 weeks usually, and you can generally, the effect starts within 3 to 5 days and peaks within 2 to 3 weeks.
Okay.
And usually for the first 10 weeks, the effect is good and it is persistent, and after that it slowly starts waning, and by week 12, in most of the patients, they will need the next dose. Okay. 30.
Question is, are you using myoblock?
ये नहीं है मुझे वो जो just a second sir. क्या है 1 ml लगाया ना, हाँ इसको पूरा निकाल दो. 1.3 ml मुझे ऐसे चाहिए. EMG needle that we use, which has 2 ports. One is this is the concentric EMG needle, This is a 37 millimeter needle and it is 27 gauge size, and there is a hub for connecting the syringe and injecting. So what we do is we connect this to the EMG machine on one side. जाएगा ना इसमें? इसी में नहीं, बस इसको पकड़ लो. Thank you. 1 ml or 0.3. ठीक है. नहीं, that's fine. That's fine. So when I dilute, usually for the neck muscles, I use 1 ml to dilute 100 units. So that means that in this 1 ml syringe, every 0.1 division contains 10 units. So when I inject in the right longus capitis, I wanted to inject 20 units. So I will be injecting 0.2 ml. 0.3 ले लिया आपने? So let me start now. उस तरफ घुमाइए neck. So this is the landmark. अब सीधा देख लीजिए, सीधा देख लीजिए. So right in front of the sternocleidomastoid insertion into the mastoid process, I am going to take the needle perpendicularly inwards. अब सुई लगेगा सर. You hear the firing now?
We cannot hear, but now some.
There is a firing like raindrops on a tin roof.
Okay.
So now I'm going to inject 0.2 ml. The right longus colli. That's done. Now I'll finish on this side, the right sternocleidomastoid. I'm going to inject 15 units. So you hold the muscle like this, and from the posterior border, enter here. Usually for the sternocleidomastoid, EMG may not be needed, but since we have used the deep muscle injection, we can as well use it for these muscles also. Left side. So we hear the firing now. So I'm going to inject 15 units. Behind the sternocleidomastoid, here is the scalene complex, which constitutes of the scalenus anterior, middle and posterior. So again in the scalene muscle, I'm going to give 20 units on the right and 10 on the left, because there is a tilt towards the right side. I want to give more units on the right.
So you're going anterior to the sternocleido,
Just posterior to
posterior to the sternocleido.
So I'm going to give 20 units here. And now I'll finish the other side and then go to the platysma, which is a very superficial muscle.
One question is, how do we decide the dose, Hila?
Sir, that I will be discussing in the afternoon session during the how I
Understood.
do it.
Right.
So once again, the longest capitis is a deep muscle, and it is slightly challenging to inject. So once again, I'll be demonstrating how we do it. उस तरफ घुमाइए. So here you see the contracting sternocleidomastoid very clearly.
Yes.
So palpate this. So you are able to feel the entire thickness of the muscle here. And then सीधा देख लीजिए. Now this is the point where I take the entry. Perpendicular, needle जा रहा है सर. Do you hear the firing now?
Yes.
Okay. So here we inject 10 units. Once again in the sternocleidomastoid, again I'm going to give 15 units from the posterior border. I just enter here. Here the firing. Then this is the just behind the muscle. We are in this patient, it's quite hypertrophic. We are able to see it very clearly. So just go here, it's quite a superficial muscle. Once again you hear the firing. Okay. So now we have finished this and we will start with the platysma. For platysma generally we don't need EMG guidance. So when we are doing the superficial muscles of the neck like platysma or the facial muscles, we generally use this 30 gauge yellow needle, and it is done, it's a very superficial injection. You will be able to see it. Just half the needle will be going in the subcutaneous tissue and then you can inject. So because it is bilateral and almost symmetrical, so I am going to give equally on both sides. Needle again. So I am injecting in 6 points in this patient. Three points on the parasagittal region and 3 points laterally here. 1, 2, 3, 4, 5, and 6. Okay, we are done. Okay.
Total units, how much you have used, Ila?
So in this patient, I have given 130 units of Zarpoton.
So one ampule is 100 units, is it?
One ampule is 100 units, and so 130 units we have used.
Okay, okay.
The question is,
Sir.
it's just like an intramuscular injection. That
Vishal, is the second patient ready?
So if the sternocleidomastoid is such a bulky muscle, how do you expect these small depots to paralyze the full muscle?
Okay, that's a very nice question. The purpose is not to paralyze the muscle. So because it is dystonic, it is contracting in the abnormal when it is not supposed to contract, and so we are actually trying to produce a paresis in the muscle.
Sorry?
Paresis. We are not paralyzing the muscle, we are slightly weakening the muscle. And when we are injecting it, the muscle, so sometimes you inject in multiple points, but here we have very little dosing to be injected. So there are two ways of increasing the spread if at all you think that the toxin spreads within the muscle. So if you want to increase the spread of the muscle, toxin in the muscle, then we can dilute it double. Okay. So 1 ml will contain 50 units in that situation, and so instead of 1 ml you will be injecting 2 ml for 100 units, and by that you can increase the spread of toxin in the muscle.
Right. Thank you. Thank you.
So this patient is a 55-year-old patient. This is another case of cervical dystonia. So I had chosen 2 different forms of cervical dystonia. One in which the patient had an anterocaput and an anterocollis. This patient is relatively a straightforward patient. If you are able to see that his neck is tilted posteriorly. So he has a retrocollis, and you can see the crease. You can see. You can see the neck crease here, and the head is also tilted posteriorly. That the posterior tilt is very much clearly more appreciated when in the in the lateral plane. We are able to see that the neck is tilted posteriorly, but the head is not tilted that much posteriorly. This is the plane of the neck, and this is the plane of the head. There is a slight tilt here also. Here you can see the crease here. But it is predominantly at the plane of the neck as compared to the plane of the head.
Right.
So what are the muscles that we will target? So this patient has been getting his injections for quite a long time. The other patient was the first, that was the first time we injected him. But this one has been getting injections for the last many years, and he has a pattern which has worked very, very well for him. So because this is symmetrical and in the midline, there is no significant tilt or turn here. It is just posterior tilt. So what we are going to inject is inject symmetrically on both sides in the semispinalis capitis and the splenius capitis muscles. So since the tilt is more at the level of the neck, so I am going to give more injection in the splenius capitis muscle as compared to the semispinalis capitis. Suppose I feel that not in this patient, in a given patient, if the tilt is more at the level of the head, then I would give a little bit more dose at the semispinalis capitis as compared to the splenius capitis. So here I am going to give 60 units in each of the splenius capitis and 40 units in each of the semispinalis capitis. With this pattern, he has been doing very well for the last 15-20 years, and so I will be following the same pattern for him. Usually in this case, we don't use, we can inject blindly also. I can show you the landmarks, but I will, because I am demonstrating it for a group of people, I will use the EMG needle so that you can hear how the firing happens also.
What has been the frequency of this patient visiting you?
He has been getting injections every 3 months, sir.
3 months.
Yeah. So in this patient, I am using a slightly different EMG needle, which is a 25 millimeter needle. This is a thinner needle, which is 30 gauge. Thank you. So let me clean up. थोड़ा साफ कर रहे हैं, ठीक है? स्पिरिट से साफ कर रहे हैं, थोड़ा ठंडा लगेगा. I am connecting the silver chloride electrodes. This is the same electrodes that we use for ECG and routine EMG. Hundred. On है शायद. Thank you. So this is the same dilution again. I have 100 units in each of these 1 ml syringes. So let me start with the right side first. So the landmark is, when we are doing it manually without this also, without the EMG also, we do inject a lot of times because this is quite a superficial muscle. You hold the hand like this just below the pinna, and at the end of your thumb, so at the end of your thumb, this is the point on the lateral aspect of the mastoid process. You have the insertion of the sternocleidomastoid, and just behind that you have the insertion of the splenius capitis, which starts from the spinous processes of the lower cervical and the upper thoracic vertebra and then gets inserted into the mastoid process and on the lateral aspect of the superior nuchal line. So in this patient, because he has a crew cut, you are able to see the superior nuchal line clearly here.
Yes.
So this is the anatomical landmark. This is where the muscle is inserted. So we are targeting the insertion of the muscle because in this particular patient you are clearly able to see that the muscle is overacting at this end.
Right.
So at this point, I'm going to go vertically here. You hear the firing? Do you hear the firing?
Right.
Okay, so I'm going to inject 0.6 ml, which is 60 units here. So once you start injecting, the sound actually goes away because it is dampened. Then I'll show you the landmark of the semispinalis capitis. Here the semispinalis capitis is the muscle that is present on both sides of the neck here.
Right.
And it is inserted between the superior and the inferior nuchal line. In this patient, it is very clearly seen here. So this is the midline. So this is the right side and this is the left side. So we are going to go just here, deep, as deep as possible. You are hearing it firing. And if you want to activate, you can ask him to push the head against your hand. हाथ मेरे आपका सर से ना मेरे हाथ को धकेलो पीछे की तरफ. Okay, okay, ठीक है. So we now know for sure that we are in the right spot, and then we inject.
How did you know once he pushed his head back? What did you notice?
So we notice that the firing increases, meaning we are in the muscle that is leading to the retroflexion of the head.
Right.
So once again, I'm going to inject the left semispinalis capitis here. This is the landmark. And we hear the firing.
Right.
But I can activate the muscle. हाथ को रख. Are you able to hear the firing and dystonia?
Yeah, a little bit.
So there is this phasic contraction. So 0.4 units, 0.4 ml here, 40 units. And then once again we will target the left splenius capitis. 1 finger breadth. Just put your thumb here below the pinna, and the point where your thumb is touching the muscle here, go deep here, just behind the insertion of the sternocleidomastoid on the mastoid process. हाथ को पीछे, सर पीछे कीजिए. Okay. So here I am injecting 60 units, sorry. Yeah. So we are done. Thank you. Thank you, sir.
Thank you.
Thank you. Thank you so much. Have we any more cases or that's it?
So we have one more case of hemifacial spasm.
Okay.
And if he would have had dystonic movements, then also it would be indicated, or then DBS would have helped him.
When we are talking about dystonia, we have this dystonia which is a phasic dystonia and a tonic dystonic component.
Right.
So tonic is usually there is a fixed posture. In phasic you have the tremor, dystonia
Right.
with dystonic tremor.
Right.
So the dosing is slightly different in both of these cases. When there is a dystonic tremor, that means that both the side muscles are acting. And then we have certain parameters, whether it is crossing the midline or it is going towards one direction. So depending on that, we say whether we want to inject unilaterally or both sides.
Right. Thank you.
So this patient has a hemifacial spasm. So as you are able to see here, the left nasolabial fold is very prominent, and you are able to see the contraction of the left half of the face. So we target the muscles. This is the frontalis muscle, which is contracting here. You are able to appreciate. And then the orbicularis oculi is contracting. The zygomaticus major and minor complex is contracting. And you have this levator labiae superioris muscle. Here, this is the levator labiae superioris. You are able to see the upper lip getting elevated, and you see this phasic contraction also. clonic contraction. When we are talking about hemifacial, we have this tonic type of hemifacial spasm or the clonic type. So we see this clonic contraction of the levator labiae superioris, and we also see that the mentalis is contracting, and this is the risorius muscle. This is not that very contracting in this particular patient, but we are also able to see that the depressor anguli oris is also contracting here.
What about the left side orbicularis oris?
So this is a frontalis muscle which is contracting. You are able to see that on the right it is not contracting, on the left it is contracting. And we have the orbicularis oculi. We have the zygomaticus major minor complex here. So I'll tell you the anatomical landmarks when I'm doing the injection, but right now we are just looking at the muscles of muscles which we are going to target.
Isolated blepharospasm is again a part of this only, no? It's a spectrum, no? This one is the extreme of blepharospasm alone.
Okay, so I will clarify that. So in blepharospasm, both the eyes are symmetrically contracting, and sometimes in patients with Meigs syndrome, you have the entire face in which both the side frontalis, both the side orbicularis oculi, both the zygomaticus major. Usually it is symmetric. Unless we are treating with Botox and one side is gone off, then it might be asymmetric. In the afternoon, I will also be showing one video in which we have asymmetric blepharospasm. But by and large, blepharospasm and Meigs syndrome, it's a dystonic disorder in which it is a bilateral symmetric disease.
Right.
Hemifacial spasm, on the other hand, usually is unilateral. In 3 to 4% of patients may have bilateral hemifacial spasm, but it is very, very rare. In hemifacial spasm, you see one half of the face and the platysma, all of them are contracting.
Right.
And how do we differentiate it from a functional patient? I also have a functional patient's video. I'll be showing it in the afternoon. So usually when someone is trying to close their eyes, the frontalis muscle cannot contract in the opposite direction. So in hemifacial spasm patients, if you see, when the eye is closing, the frontalis is contracting in a different direction.
Okay.
So you are able to see that even though the eye is getting closed, the eyebrows are getting raised. So that means that both these muscles, orbicularis oculi and frontalis, are contracting independent of each other.
Right.
So it is a true hemifacial spasm.
Very nice. Thank you.
Thank you, sir. So in this patient, I am going to target the dosing. I'll tell the dosing. As I told you, I am going to use this yellow needle, which is a 30 gauge needle. It's a very fine needle. When we are dealing with the eye, we generally don't use eye and the face. We generally don't use spirit or sterilium to clean it. We just clean it with normal saline. थोड़ा फेस अभी साफ करना है. आंखें बंद करके रख लीजिए.
Question is why so?
Why what, sir?
Why only saline and not?
So because the sterilium can sting the eye when the because it enters the conjunctiva, we don't want that to happen.
Yeah. Betadine could have been used a little bit.
Okay, thank you. So I am going to, this patient is not very much bothered by the platysma contraction. So we are going to target the area. In general, in such patients, we ask what is the most bothersome symptom and treat them. So in this patient, she is quite bothered by this flickering of the eyes as well as left eye as well as this face. So how do we inject? I am going to inject the orbicularis oculi in 4 quadrants. So let me show you. This is the pre-tarsal part of the orbicularis oculi, and it is just below the skin. So what I do is, I am going to stretch the skin like this so that there are no creases. Stretch the skin like this so that there are no creases, and just above the line of the eyelid on the medial aspect, I am injecting 2.5 units. And in the lower part also, stretch the skin like this and 2.5 here. When we are doing the lateral part, in the lateral side, now when we are doing whether medially or laterally, you go away from the levator palpebrae superioris. So when we are doing this side, on the left side, I went like this. when I am injecting the lateral part, I am going to go like this, because the muscle that I am most worried about is spread of the toxin into the levator palpebrae superioris, which can lead to ptosis. So here again, I am stretching the eyelid so that there are no creases. And in the lateral aspect, here 2.5. And in the lower part, again 2.5. Now I am going to inject 2.5 units here in the frontalis, in this part which is contracting, this part. .5, and the maximum contraction is happening here, and this is quite a big muscle, the zygomaticus. So how do I identify the muscle? One thing is you are able to see what is contracting, but what I want to avoid is this part. This is called the danger area of the face. Keep away from it as much as possible, because if there is too much of spread here, it is going to lead the upper lip to droop. Then it will look cosmetically very bad. So what I tend to do is, if at all you want to target this part, keep as close to the upper part as possible, because if it spreads, if it has to spread, it will spread down. But if you inject too low here, then it is going to affect this part, which I don't want. So how do I do that? From the upper border of the pinna, from here to the angle of the mouth. This is the line, and in the midpoint here, this is the point I am going to inject. I am going to inject 5 units here. Injection lag raha hai abhi. And I have 2.5 more units left, which I am going to inject here in the depressor anguli oris. We are able to see the muscle contracting here. And we are done. So this is a very effective form of treatment, and there is absolutely no blood or anything coming out. And patients are very satisfied with botulinum toxin, and most of the patients with focal dystonia. And for hemifacial and blepharospasm, for focal dystonia, botulinum toxin is the treatment of choice. And if it is not working, then of course we ask the neurosurgeons to help us to, there are studies in cervical dystonia and other Meigs syndrome, in which patients have undergone deep brain stimulation. In some instances, pallidotomy. Our own surgeons have operated some patients for us. I'll be showing the videos later on. And in hemifacial spasm, sometimes there may be a neurovascular conflict, and in such cases, if the patient is keen on getting a surgery done, then we do refer patients to our neurosurgeon.
Just a clarification, like
Sir.
the eyelid
Sir.
that contains the levator palpebrae superioris, and then you have the orbicularis oculi all around. So you injected it right at the bottom of the lid. So gravity would not have helped it to spread upwards. If you would have put it somewhere higher up, there would have been more chances for the Botox to gravitate down because of the gravity.
Okay, let me tell you about that. So this orbicularis oculi is a circular muscle around the eyelid.
Right.
So when we are injecting like this in the lateral aspect, so when the fibers are going around, the tendency of the toxin is to travel around, and it spreads all around. But the levator palpebrae superioris muscle is quite far away from the point where we are injecting. And so we are not, technically we are not injecting the toxin anywhere near the LPS, which is vertically going down like this.
You want to avoid levator palpebrae superioris?
Yes, correct.
So why so?
So levator palpebrae superioris, the action is to keep the eyelid open. I don't
No,
want.
because my only concern was, even for orbicularis oculi, the location that you have chosen would not be helping the muscle spread. But that is just at the periphery of the margin that you have injected of the eyelid.
Sir,
I don't know.
No, basically the muscle is circular. So when we inject
If
in
you
this,
would have put it on the higher side, no, the outer periphery of the orbicularis oculi, I feel the spread have been better than what you have done in the lower line. You have just put it the margin of the eyelid. I was a little surprised at why you're doing that.
actually we are injecting the pre-tarsal part, which is the muscle which is involved in the milder conditions.
Fine.
So there are three parts of this muscle, which is the pretarsal part, preseptal part, and the orbicularis oculi pars orbitalis. So when we are going farther away from the eyelid, from the margin of the eyelid, so we are going to inject into the pars orbitalis part of the orbicularis oculi. So when there is a very severe condition, very severe blepharospasm, in
Right.
which when we are injecting at the periphery of the eyelid, it is not working, then we do tend to inject the pars orbitalis also. So we can inject it even as lateral as this point.
Right.
But we don't do that in mild cases. We do inject in, we inject up to 72 units, 80 units in both the eyes when there is a very severe blepharospasm bilateral.
She's got excellent result. We can already see the result.
Thank you, sir.
What
Thank
are
you.
the chances of facial paralysis after this?
Facial paralysis. So basically we are injecting very little doses. Right now I injected just 20 units. The purpose is just to weaken the muscle on the left half of the face. Sometimes if there is too much of facial weakness, there is significant asymmetry of the nasolabial fold. In order to preserve symmetry and cosmesis, we do inject on the other side of the face also to balance it out. So we do tell them that they can get weakness of the face, but most of the times that is the intended outcome that we want to. And most people do very well without
When
significant
will be
facial.
the next follow-up of this patient? When are you going to see her again?
It will be after 3 months, sir.
No, but if you see her next day, will you not be able to supplement a little bit more?
So what I do is, especially when I do the first injections, I call the patients after 2 to 3 weeks. So if I feel that the first injection has done very well, then we ask the patient to come after 12 weeks after the first dose. And if I think that it is insufficient, then I top it up also. So I had a patient whom last week I had injected, and the patient had insufficient response. So last Tuesday I topped it up.
Thank you very much.
Thank you, sir. Thank you. Thank you for the opportunity.
ठीक है. So I think we have come to the end of the live operative session. So I think it was very nice. We thank all the faculty who were there for the excellent demonstrations. And we'll join back. We'll break for lunch right now. So it is going to be, we join back at 2:30. So we can have a nice lunch. Same place where we had the breakfast. And when we come back before 2:30 for the afternoon talks where we will discuss the morning cases.
We'll have video session. Please join here in hall by 2:30 p.m. Please. Thank you.
मेरे पास वीडियो नहीं है, मेरा स्लाइड्स नहीं.
You are the boss.
आज वीडियो की इमेज कंटिन्यूअसली रहता है.
Not specific to the
Main deviation.
It's everywhere.
Key points.
What do you want to see?
Good afternoon, everyone. Now, post lunch, we will start with the video session for today. For this session, I request Dr. Tushar Agrawal and Dr. Vaishnavi Lingareddy to kindly chair the session. Dr. Tushar, please, and Dr. Vaishnavi. I think
Very good afternoon to all of you. So we are starting off this afternoon session. Dr. Ashish Tandon is the first speaker. He's going to talk about epidural blocks.
So, good afternoon, everybody, and thank you, Deepak, for this opportunity once again, dear chairpersons. So, though it's a video session, but I don't have videos, I have more of photographs. So, it is a photographic session. And it's not just for epidural blocks. I'll give you an overview, so, sort of Okay, thank you. So this is blocks for neurosurgeons, and these are the set of blocks that I sort of use. ये आगे कैसे होगा भाई? हाँ? ना प्ले हो रहा है किससे? Okay, fine. So I hope you नहीं चल नहीं रहा. Okay. So I hope you remember this scene from Three Idiots, you know, where he's talking about the pen which was invented in space, and then Amir Khan asking why can't they use a pencil, you know. So something very similar for our pain procedures as well. When, you know, you can get the same result doing simpler procedures, then why to lift heavy to build the same set of muscles? So why should I learn blocks? Well, it helps clinch diagnosis many a times. So that's very important. And we may not be aware, but if you go through literature, it has always been part of the treatment algorithm. So what are the spine blocks that I use? The most common block that I use is erector spinae block. And why is it so common? Because all the cases that I operate, I use a erector spinae plane block. It's the easiest plane block to do, and pain relief is excellent. reduced requirement of opioids. The next that we showed today, transforaminal blocks, which could be a selective root block or it could be a transforaminal epidural steroid block. Then facet blocks. These facet blocks could be intra-articular blocks or it could be medial branch blocks as well. So you can thereafter take up for a RF lesioning as well. And then I'll focus today more on epidural blocks, which could be cervical, dorsal, or lumbar. Caudal epidural blocks, SI joint blocks, ganglion impar blocks. So these are the list of spine blocks that I generally undertake in my practice. Then the other pain blocks for carpal tunnel, giving steroid, it gives excellent results and it helps you with the diagnosis as well. Stellate ganglia block, which was discussed and showed today. It is the latest armamentarium and it was Deepak who sort of pulled me into stellate ganglia blocks. RF lesioning for trigeminal that we showed today. And then you have blocks for headache and migraine. Though I must confess that except for occipital neuralgia, I have not done any blocks for migraine myself. So why blocks? Well, there is a very weak association between imaging and cause of chronic pain. So acute cases is fine, but for chronic back pains, chronic neck pains, the MRI or the CT scan is not sort of diagnostic. So that is why you need blocks. And only in 15% of cases, the source of chronic pain is picked through imaging alone. So you need good history and examination, imaging, and then blocks. So for me, the indications for blocks are diagnostic and therapeutic. Now, what is the difference between a diagnostic nerve block and a therapeutic nerve block? So obviously a diagnostic nerve block it helps diagnose the source of pain. So which is the pain generator? It will pick up the pain generator for you. So it pinpoints pain generating root level or facet. For diagnostic nerve root blocks, you use lidocaine 2% and 0.5 to 1 ml along with dye. And you say that you have a positive result if at least 70% of pain is relieved. Only after that will you say that it is a positive result. And diagnostic value always would remain moderate. So it is in combination with imaging and your clinical diagnosis. The frequency of blocks, well, this is another frequently asked question. So it is safe to do almost 3 to 4 blocks per year in a patient. And the minimum gap that you need to maintain is more than 2 weeks for another block to be given. Contraindications include anticoag, local site infection or systemic infection. In pregnant women, you need to use ultrasound and if there is allergy to contrast or local anesthetic. Now, this is a big debate, which type of steroid. So you have particulate steroid and non-particulate steroid. In particulate, you have triamcinolone, methylprednisolone, betamethasone. But the problem with particulate is that they can form coagulum and it can cause thrombosis of the spinal vessels or important arteries. And there are reports of causing paraparesis, paraplegia also. So that is why, though the incidence is low, or I would say rare, but still it has been reported. And you can have spinal cord related issues. So the next choice is non-particulate, and you have dexamethasone. The particle size is 10 times smaller than RBC, and they do not aggregate. Okay. So why people tend to use particulate rather than non-particulate, and the reason behind it is there is a thought that particulate steroid remains there for longer time and there is longer duration of pain relief. However, if you look again to meta-analysis, there is no difference whatsoever for functional or analgesic outcome between the two. What this means is that if I'm using Decadron versus a particulate, the duration would remain the same and the effectivity would remain the same. And so personally, I don't want to take that risk of using a particulate steroid, especially when I'm near the cord. Otherwise, you can use particulate steroid. The rationale of steroid use, I've already elaborated today while I was performing the surgery, that it inhibits phospholipase A2 and inflammation. So it is basically to reduce the inflammation. Now, if you look at this study by Ryu et al., so suppose if a person uses just Sensorcaine or Bupivacaine, or you use steroids. So if you are using epidural steroid in a case of acute disc prolapse, 23% would require surgery. And if you're just using Bupivacaine, almost 67% would require surgery. So combining it with steroids has a great role. Now, this is another very important slide, and one needs to understand this, that viscosity of different local anesthetics is similar. So what I mean by this is, whether you use lidocaine, Sensorcaine, Ropivacaine, the viscosity would remain the same. So the flow of all these three would remain the same. However, the viscosity of dye is higher. And what does this mean? That if you are injecting 1 ml of dye, suppose, and if it is spreading to 2 levels, then be rest assured that if you are using 1 ml of your anesthetic, then it is going to spread more because it is less viscous. I hope I made this point clear. Okay. So if you are seeing 1 level, then if you are giving the same amount of local anesthetic, it is going to spread more rather than less. The volume would of the drug would decide the specificity. By this, what I mean is whether it is a diagnostic or a therapeutic block. Suppose if you want to just block one structure, it has to be small volume. Whereas if it is a therapeutic and you know the pain generator, then you can increase the volume of the drug as well. So higher volume, they would be spread to adjoining structures and it decreases the specificity, but then therapeutic value increases. For pregnancy, ultrasound guided blocks if necessary. But again, there was a question today, I think, during the discussion for ultrasound. When we use ultrasound, somehow our positivity rate is lower, especially for spine blocks. And when we confirm with, despite using ultrasound, when we confirm it with C-arm, at times we are not at the target point. So, still in most of the cases, we prefer C-arm based technique. The other question that comes is fluoroscopy versus CT scan. So fluoroscopy is faster, it is widely available, better for non-axial view, but a fluoroscopy will not provide you axial views. On the other hand, if you are using CT scan, then you have excellent axial and 3D views. You can exactly view where the tip is of the needle. And the operator radiation is avoided. However, the patient gets more radiation. It is more time taking as well. Now, a few slides dedicated to erector spiny plane block. It is a fantastic block. It's a facial plane block. And if you look here, so the needle is going and hitting just the tip of the transverse process. And it is here that the drug is going to spread. So let your needle go there on AP and you inject about 20 ml on one side and it will sort of give good pain relief in the perioperative period. So Again, our experience has been a dramatic change in the post-op pain of the patient with the ERAS program and erector spiny plane block. So when you combine ERAS with erector spine pain blocks, the requirement of opioids has drastically come down and the patients can be discharged earlier. So the technique I've already shown you, there's nothing much in it. Tip to lateral, 1/3 of the transverse process. Let your needle hit there. Just withdraw about 0.5 millimeter to 1 millimeter. And it is done either fluoroscopic or ultrasound guided, and you can push in the drug. So 20 ml of 0.25% or 0.2% ropivacaine is deposited. And as you can see, this is ultrasound guided. This can be done to reduce radiation, or in the post-op period, if you have not put in a catheter, or in the post-op period where you've done long segment fixations, you've corrected scolies or kyphotic deformities or multi-level degen scoli, then you can again use it through the ultrasound, because there you may not have a C-arm in the ICU or in the ward. So you can push in ultrasound guided. So this figure shows you the flow of the dye and the amount of drug spread. So you can inject the drug on both the sides if you have done a bilateral fixation. However, I would like to comment that, you know, everything is not, it is not as rosy just if we keep on doing, because there are cases where somehow 1/3 of the patients would not respond to it. And that is what I have seen myself. So 2/3 patients do excellent, but 1/3 maybe either we are not injecting it properly or for some reason. So you can have a success rate of about 66 to 70%. There are certain complications, partial lower limb weakness, which is transient, local toxicity of the drug as well. Now coming to epidural blocks. So epidural blocks I use 3 types of blocks. One is the midline interlaminar approach. Deepak, you can inform me when to stop. This is a big lecture. Whenever you feel, I can stop. So these are the 3 types of epidurals. One is the interlaminar approach, center, midline. So the drug will flow both sides. The other is the recently introduced paraspinal approach, wherein you have more onto one side and the root gets blocked, or the transforaminal block, which we saw today. I don't think so we had epidural blocks today, midline. So this was the trial I was talking about, the SPOT trial, Spine Patient Outcome Research Trial. So in this, patient of disc herniation receiving epidural steroid injections, only 20% required surgery versus 57% requiring surgery in the non-steroidal group. So, you know, almost 30-40% of your patients can avoid surgery if you are using epidural steroid. This could be either interlaminar or transforaminal. Okay, transforaminal versus interlaminar, transforaminal has better results. So, because it is more specific, whereas an interlaminar it gives wide distribution of pain relief. I'll skip transforaminal because that's for tomorrow. So epidural block, what are the indications? Disc herniation, radiculopathy, spinal stenosis, sympathetic mediated pain or pelvic pain. For cervical epidural block, indications include cervical PIVD with radicular pain and chronic neck pain. But it is more for cervical PIVD. And I can assure you that a lot of your patients who have this radicular pain with Bacodes positive, they'll come to you, you keep on giving medications, they don't agree for surgery. Try this, it gives excellent results for cervical radicular pain. So ideally C6-7 or C7-D1 is the position, and I take a midline first to confirm. I can go on to one side as well. Above C6, I avoid my needle entry because there's very limited epidural space and I can puncture the dura. So I use a 22 gauge needle, C-arm, steroid, and the other drugs. So the patient is positioned in prone, head flexed. On AP, I look in for, so no headrest, just plain table, which is radiolucent, and then look for midline. Always enter into the midline and let your bevel take you onto the side that you want. Again, tilt the C-arm position to give an end-on view. So here, if you'll see, this is what, so here is C7 T1 interlaminar space. You should see this space, and thereafter you gradually get your needle in. At one point of time, you will have that gritty sensation. Then after that, go very gradually, and then what I do is, after this syringe pushing in the air, I take a lateral shot, and this is the epidural dye spread that I get. So it gives excellent results, as I have mentioned. The rest of it remains the same. Similarly, it is for lumbar epidural blocks as well. It is also a must-use tool in your patients who have failed back syndrome. A few of your patients would improve on this as well. And here, as I have shown, this is a midline technique, opposite side technique, or paraspinal technique. Okay, but the technique to penetrate the ligamentum flavum remains the same. It will have a smooth entry, and at one point of time you will start feeling gritty. So use 2 hands and go gradually. And then at one point of time it will suddenly give way. At that point you put in a syringe and inject air. And once you've done that, you put in a dye and confirm. So I think here you can see dye. This is an interlaminar, but it is paraspinal, and you see the drug and the dye going only on one side, not affecting the other. Thank you. So here drug and the root spread is only on the one side. The other side is not. Okay. So I'll skip facet joint and
you can just talk about the diagnosis, like facet joint, how do you diagnose?
okay.
Indication of facet joint.
Okay. So facet joint pain, okay, so facet, you'll have lumbar facet and you'll have cervical facet. This is the facetal pattern of pain that you have. So for C2-3, it will be suboccipital, occipital area, C3-4 going a little down, and up to C6-7, it is going to spread here. So this is the typical pattern. But I want to draw your attention to this extremely important slide. And I must tell you that when we are residents or even in our clinical practice, we don't look at this data. 67% of chronic neck pain is secondary to facet. How many of us look at the facet while we are diagnosing neck pain? We don't even consider. Thoracic pain, 50%. Low back pain, another 50%. So these are very simple blocks. So any patient with chronic back pain or chronic neck pain, please consider facet as the source. It is one of the commonest source. So for low back pain, the commonest, chronic low back pain, commonest source is facet. Then comes your lateral recess, and finally the SI joint. And this is the pain pattern for the facetal pain. So I suppose this is what you wanted to have a look at. So this is the type of pain pattern, but it is not going beyond the knee. Okay, okay. So, for technique, see, as far as the intra-articular injection is concerned, it is quite simple. You get the Scotty dog appearance, you'll see the facet joint, and you can inject, but you have to inject very limited amount of drug into the facet joint, and generally it tears the facet capsule, and the drug can penetrate into the epidural space as well. So generally, intra-articular facet injections are not preferred. What is preferred is the median branch block. Now, one facet joint is supplied by two median branches at the level and above. So you have to block two nerves. One is above and one is at the same level. So generally, ideally, this is going to supply here, and another nerve for this level is going to supply here. So you need to block two to block this facet joint. And where do you target? It is the junction of the superior articular process with the transverse process. So superior articular process and transverse process, the junction, there you have the median branch. You place your needle there and you can deposit the drug. So that is for the lumbar facet. For cervical facet, you have cervical pillars, but I'll discuss in one of the next lectures. Trigeminal, I have already talked. I'll be speaking on trigeminal tomorrow. So what are the take-home messages? Well, learning spine block should be part of all neurosurgical curriculum, and it is good that we have come out of this sleep and we have started acting on it. It is part of the management algorithm, so it's very important. There are wide varieties of block for spine and limb related pain. You can use any of these three modalities to target as per the availability and your training. The good thing is you guys are doing aneurysms, clipping aneurysm, doing petroclival. Learning curve is not steep. Do 2-3 cases and bang, you can start doing it in your practice. So that is something good. And blocks can help prevent many invasive, unnecessary procedures. So that is another important take-home message. These are the two fellowships that we run, and if anybody is interested, can join us for 2026. Thank you.
Very useful topic indeed. Any questions from the house? So is there any particular reason, or we can add on steroids?
Yeah. So the reason is, see, here you use steroid where there is inflammation. Okay. In erector spiny block, those nerves are not inflamed. Okay. So you are putting local anesthetic there to sort of tide the 2-3 days that you require. In any case, steroids, when we give, whether for epidurals or transforaminals or anywhere, it starts acting after 6 to 24 hours. So the action is delayed. So initially you put Sensorcaine or Ropivacaine because for the first 24 hours you need. So here also, because it is tiding the perioperative period, you're using Sensorcaine, but you can add steroid. But then it will be a lot of steroids.
In general, usually for any planar blocks, we don't prefer steroids. Instead, we can go for quantiplex catheters if you want the duration of action to be longer. Like in case of you people doing long segment instrumentations, or you're doing more than 2-level T-lifts, patient is having cage and multiple levels of screws and rods in the back, and patient is having excruciating pain and pain scores are more than 5, then why can't you put erector spinal catheters? So choose a mid-level, give the block, give the bolus doses. We can use epidural catheters, the same thing. Hit the TP, give the bolus dose, thread the catheter, and you can happily use 0.2% ropivacaine, which doesn't cause much of toxicity, and give it at 5 ml per hour on bilateral. Hardly will be giving 10 ml per hour, which doesn't cause any toxicity even for a patient who is less than 50 kgs. So that is what we practice, and patients are actually happy, doing even good rehab, and they will even cooperate for doing physio early.
The other block, when it comes to planar block, which is very helpful for us, is the serratus anterior block. So a lot of our trauma patients also come with rib fractures and lot of chest pain. And serratus anterior planar blocks are excellent. You can use it ultrasound guided if you have it in the ICU and put in the drug, and these patients cooperate a lot. Compared to, yeah.
Until unless the patient is having an ICD, ICN blocks will not help for the patient having only isolated rib fracture actually. So if the patient is having multiple level rib fractures, ICN will not actually help, because it is purely most of the patient having pain because of the chest movement, especially if the patient is having flail chest and if you have put the patient on NIV. So in those kind of cases, we would actually prefer thoracic epidural continuous infusion or serratus planar block, not the ICN blocks. First of all, they will not cooperate for ICN blocks.
And again, these blocks are very easy and they will give a lot of relief to your patients.
Thank you. Thank you.
Thank you. Thank you.
I would like to invite Dr. Millen, sir, to speak on DBS.
For convenience sake, we have divided time into 12 minutes, around 3 minutes of questions. 12 minutes of each speaker.
No, these facet, no. So we give 2 facet blocks. By that I mean 2 sittings of median branch blocks. And if the patient is responding, then we do RF ablation of the medial branch. And then even that, the patient will have a recurrence, but you will have a pain-free period of 6 months to 1 year, 1.5 years.
अरे ये ठीक है, वहां से कुछ मत करो, मैं करता हूँ. ओके, ये स्क्रीन अपने आप चेंज हो रही है, तो मुझे करने दो बस. हाँ. Thank you very much. Again, I have bunch of videos for DBS, but nothing specific for DBS for pain. Primarily because DBS for any cause is a DBS, so the videos are not very different. So I thought I'll just pick up some of the important points that are essential for DBS for pain. And these are just my conflicts of interest. And so I'm going to use basically 3 points, because DBS as such is a very, very simple surgery. It's not a complex surgery. What decides everything is the indications, patient selection, and sometimes technique. So these are a lot of DBS cases that I personally have done, and a lot of indications. Pain is one of the very important indication in this. There are 2 things. When you are doing DBS for any indication that are important, you should know. 1 is your stereotaxy. You should know that. And 2 is your 3D anatomy in subcortical nuclei of brain. And then there are 2 things which are essential for good outcome. 1 is proper selection, and 2 is proper placement. If you have those 4 things, your DBS outcomes, whether it's for movement disorders or for pain, are going to be excellent. It's a teamwork. As I always say, DBS is not a solo thing. You need to have a team. You need to have a team of psychologists and neurologists and programmers and neuroanesthetists. So for pain also, you need a team, you need a pain management person, you need a psychiatrist, neuropsychologist, all those things. Surgical candidate for pain DBS. So generally, the smaller the pain, the better it will respond to DBS. For any pain intervention, chronic pain intervention, the smaller the pain, it will respond much better than the spread out pains like hemi-body pain or whole body pain. Neuropathic pain, by and far the best pain that responds to neuromodulation. And then comes nociceptive pain, and then comes visceral pain. Structural abnormality, lesion in the region of thalamus is a problem because you cannot put in DBS or you cannot program. So have to make sure there is no structural abnormality in brain, especially where we are going to put the DBS in. Neuropsych has to be normal. There don't have to be any secondary gains. And what we are talking about when we talk about pain, neuromodulation, is chronic pain. And chronic pain is a completely different animal than acute pain. So this is all about chronic pain. Goals of DBS surgical procedure is complication avoidance and location. If the location is good, you will get good results. Doesn't matter which DBS. Normally we use the stereotactic frame, but nowadays we are using lot of different things. We are using frameless, we are using custom-made stereotactic tripods. Even in India, those are available. So when you put the stereotactic frame, there are some basic things that you should know. The frame has to be parallel to ACPC line, and you're able to find it out from the planning station if the X and Z coordinates are different. You should not tighten the screws too much. What that does, it warps the frame, and when the frame gets warped, you will be off by half or 1/4 of a millimeter. Do not move patient holding the frame. So whenever the patient is moved to the CT scan after putting the frame, tell people not to hold the frame. As they say, plane crash does not happen because of one mistake. A DBS lead is not misplaced because of one mistake. There are lots of small mistakes that add up. And some of them is doing a wrong sequence MRI scan, not doing the continuous CT scan, which is important. There should be no gap between the cuts. Thickness should be 1 millimeter. Not fusing right, making sure the screws are tight after the CT scan is done. So you even tighten half a turn one of the screws, your whole stereotactic space will be shifted. So don't do that, don't make it too tight. Make sure it's parallel to the ACPC line. And then we use the planning station, S8 planning station for most of it. Nowadays we started using Brain Lab planning station also. Stereotactic localization in pain DBS is primarily done anatomically because there are not many microelectrode recordings available. The targets for brain DBS primarily are a lot of targets, but these targets are thalamus, nucleus accumbens, posterior hypothalamus, PAG and PVG. The commonest one I have used is thalamus, and I generally use Morell's atlas. That's different from Shattenbrand's atlas. In thalamus, the commonest target I use is CL. It's a nucleus centralis lateralis, and this is one of the very interesting nucleus. I'll talk to you about it tomorrow. But this is a nucleus which is responsible for everything that happens in our brain. And it's not possible to target it based on the normal SB atlas. The second common target is sensory thalamus. That's the one, the ventralis cordalis, nucleus ventralis cordalis. That's the most posterior nucleus. That's the one we use for pain. Again, what's important is if you want to see thalamic parcellation, then you need a 7 Tesla MRI scan. We don't have that. So we have to go by ACPC targeting. This is one of our patients where we targeted the posterior thalamus for pain. Normally, the thalamus sounds like popcorns bursting, and that's when you know you are in motor thalamus. And then you go a little bit further down, and you will be able to stimulate and find out which part of body feels the tingling, numbness. Because the anatomic parcellation in thalamus is amazingly beautiful. So if you have face pain, you will have face tingling. If you have hand pain and you target the hand, you will have hand tingling, and that's how you know. This is one of our maps of mapping 2 CL and 1 sensory thalamus. I'll talk about all this in detail tomorrow in my pain DBS talks. Again, the other problem is sometimes you have to put two leads in the brain, and then it's a problem to keep both the leads through one burr hole. So you have to do two burr holes next to each other. And then those two burr holes becomes a problem because you cannot put one cap. So you have to sometimes drill out the caps. So these are little technical issues that you need to know. Post-operatively, these patients, the leads are externalized, they stay in EMU, and we do electrocorticography and as well as surface EEG, make sure the thalamocortical dysrhythmia goes away, and make sure patient has pain control, and keep on changing the programming. And at the end of 7 days, if the patient has more than 50% benefit in pain, we implant it. And implantation is pretty standard. Programming is also pretty standard. Most of these patients respond very well to bipolar settings, low rates, normally around 60. The rate should not be less than 25 and not multiple of 3, because that could induce seizures, because that's where our thalamus normally, the anterior thalamus normally fires. Cycling also helps. So that's pretty much what I wanted to talk about, how I do it. Theoretical details about why I do it, we'll talk tomorrow. Thank you. Any questions?
So what are your thoughts on lesioning?
I do a lot of lesioning also. So, but they wanted me to talk on DBS, so I'm talking on DBS. The CL thalamotomies, they work extremely well for most of the chronic painful conditions. And nowadays, since we have HIFU, I used HIFU for thalamotomies. HIFU is a MRGFUS, that's MR guided focus ultrasound. And we use that to make absolutely precise lesions in periventricular gray, nucleus accumbens, but mostly centrolateral thalamus. And that works even better than DBS. And there is no system maintenance required. In about 30% of, I've been doing MR guided focus ultrasound since 2010-11, and we started doing it in pain patients in 2012. You will see some resurgence in about 30% of pain patients, but it's never be as bad as it was before. Even RF thalamotomies, CL thalamotomies, they were beautiful, as good as DBS.
And so, what about Parkinson's and tremors? Do you use lesioning there as well, or?
Yeah, I tell patients this is like, we do lesioning in patients who cannot afford. So dystonic storm patient comes in and you have to do something, we'll do lesioning. Or patients with dystonia, poor patients, they cannot afford, I'll do lesioning. Older patients with tremor dominant Parkinson's, I'll do lesioning. Young patient with akinetic rigid Parkinson's, I will always do DBS. At least I will always advise DBS. HIFU, if it is possible, I would do that in essential tremor patients. Nowadays, a lot of people ask me, should I have this or that? And I always tell them that it's like stenting, difference between stents and CABG. You have a DBS, it's guaranteed for 20 plus years, because we know, I've been putting DBS since 2000, 2001. So I know for 24 years they work. This has come 10 years ago, and already you're seeing in tremor about 30% patients will have significant recurrence in tremor. But it doesn't involve surgery, the focus ultrasound. You are home in 3 hours. So if you want a stent, you should go for it. So. But I mean, they are not competing. I think they are complementary. Patients who want ultrasound are those patients who never wanted DBS because of the fear of surgery. Any young patient, when you tell them that these are the two options, these are pros and cons, most of them will opt for DBS. But those who did not want surgery and were afraid of surgery would never have come for it anyway. Those will come down for HIFU. So I think these are complementary things, not that one is better than others.
2-3 questions, Dr. Mohan. One is that although it's anatomical targeting, you still prefer to do it under local to see for, you said the sensation or whatever?
Yeah, most of the surgeries we do are under local anesthesia, almost 95, 99%, except it's a child.
Okay. So
But
one
yeah, adults, local anesthesia.
local anesthesia. The second is in the hierarchy where DBS comes in or lesioning comes in and all the pain management algo. So you would keep it last, or you would think of putting it in between somewhere?
Last.
Absolutely last.
Absolutely last. So most of my patients who had very good results after DBS are the patients who had 12, 13 surgeries for pain. I mean, they're not the first. So anesthesia dolorosa, multiple RF lesionings, microvascular decompressions, blocks, cervical sympathetic blocks, all these things, and they still have this amazingly bad deafferentation pain. I cannot put peripheral nerve stimulators. If I could put peripheral nerve stimulator, I will do that first. Because whatever you do, the pain is going to be reduced only by 50%, 60%. So why to increase the risk? Or patients with CRPS, bad CRPS, had morphine pumps, had Priol pumps. I had a ballet dancer. She twisted her leg and developed CRPS. And she had everything, spinal cord stimulators, everything. Ultimately, we ended up doing DBS and she had some benefit. So yes, at the end, absolutely at the end.
And so, when we talk about DBS, motor cortex stimulation and spinal cord, so first you will go spinal cord stimulation, then motor cortex, then DBS?
Depends on the type of pain and location of pain. So if it is leg pain, anything to do with leg, I would rather try spinal cord stimulation first, unless there is a big midline myelotomy or damaged spinal cord. Again, you cannot do motor cortex stimulation if it is a leg pain, because the leg is on the medial side. So you can only do motor cortex stimulation for face, upper limb, trunk pain. So all these little things taken together, you make a decision in every patient. But that sequence, spinal cord stimulation first, and if that's not working, then either motor cortex stimulation. Or now, why spinal cord stimulator is not working is also something you need to look into. You need to do fMRI scan, bold fMRI scan, and see if there is activation of right areas. And if that's not there, you revise it. In spite of activation of right areas, if you are still not getting benefit, then you shift to medial pain pathway. And motor cortex stimulation is medial pain pathway, because that's not the lateral pain pathway. So that's not the that's the affective pain pathway. So you shift to affective pain pathway, or you do nucleus accumbens DBS. Again, outside sensory, just the affective circuits.
The more you read, the more you feel that you don't know anything.
Oh, pain is amazing. Pain is, it's another field. I mean, by no angle, it is a low-hanging fruit. Pain in itself is a specialty, chronic pain. Acute pain, maybe not, but chronic pain, you have to be a psychiatrist and you have to be a counselor, and a lot of things you have to be. Yeah. Yeah. No, I mean, if it's a thalamic stroke, you cannot put a DBS there because your substrate is already damaged. So you go for nucleus accumbens DBS. So we done a lot of thalamic pain syndromes which we treated with nucleus accumbens DBS. Sometimes, depending on which part of body thalamic pain syndrome is significant, like if it's only involved upper limb, I'll put a cervical spinal cord stimulator. Then again, I probably will try a paddle lead in the cervical spine first, because that works better than nucleus accumbens DBS. With nucleus accumbens DBS, the pain doesn't go away, but the patient doesn't care about it. So patient's quality of life improves, pain stays. I done singulotomies also for post-stroke pain. We treated about 20 or 25 odd post-stroke pains. It's a difficult condition to treat. Then probably go for DBS. That's the only thing that can help. Right. So again, you go to nucleus accumbens because your thalamus is damaged. You cannot do anything with that. And you have to go to the contralateral thalamus. Ipsilateral, there is no point in going.
Thank you.
Thank you.
Call upon Dr. Deepak Yogipal. He's going to talk on resort pain.
So good afternoon. I'll be talking about again chronic pain management as Dr. Millen talked about the final. So in this also when we fail medical therapy, we go on to DRES, the surgical option, and it's not that DRES is a panacea. It works in a lot of patients, 70 to 80%. But if it fails, then we are left with nothing except the DBS or lesioning. So I think we all need to know that there is a hierarchical pathway. We cannot condemn the patient. Most of the time we say, okay, nothing more can be done. But at least we should give them the option that there are things available. So DRES, it's a very elegant and nice way of pain management, especially in intractable neuralgias, especially in the upper limb. And if you look here, this is the area, this is the posterior sulcus, and gracilis and cuneatus are there, the fibers of the posterior columns, and this is the lateral corticospinal cells. We go in between these two tracks. So there is a definite sulcus here, and this is the dorsal root entry zone is called because the dorsal roots come out from this dorsal columns. So they will be coming out from this in this line. So we have to go anterior to it, anterior to the roots to be in the DRES zone. I hope that is clear. Previously we had Dr. Tiara, who had come in from Japan, who actually demonstrated this technique like one of our operative workshops for pain. And this is a video. So I will, because this is a video session, so I'm just showing the video out here. So this was again a post-brachial plexus neuralgia. Brachial plexus neuralgia, we usually wait for pain to subside. And usually most of the time it subsides. This is a laminate midline incision which is done cranial here, caudal here. And so standard, usually we do a hemilaminectomy on the side where the pain is. So if you have got a left brachial neuralgia, we'll be doing on the left side. So because this is the right sided, this was cranial. So we are doing a right, we reversed it now. So this is cranial, so we are doing a right hemilaminectomy. Then we open the dura. The important thing to note is dura is opened very near the midline because the DRES zone is quite near the midline. One of the most common mistakes which we do is that just a minute, this computer, is that you go to lateral to the what I would say from the midline, and when you open up the lateral masses, then there could be quite a significant amount of bleeding. So it is very important that you don't drill the lateral masses, stay medially, and from the midline to the lateral mass, that's the only amount of area you need to open up. This video is stopping intermittently on its own. So this is what we are seeing. So this is the cranial, as I said, these are the C3 roots coming out here. This is the DRES zone. This is autolyzed roots which have undergone Valerian degeneration. So there is neovascularization out here all. So I think all of you can note very nicely, we are able to see this. So what we have to do is we have to coagulate the superficial neovascular vessels, vascularization, and open up this level. So the roots are more towards the medial. So this is coming from the dorsal columns. And what you can see here is, as I open it up with scissors, this is our own innovation. Instead of using any bipolar and opening up, bipolar we use just for coagulating. And as we open it up using a micro scissors, what you can see is, you can see these vertical vessels, which I again show when I, so these vertical vessels are seen, which are subpial in nature, which show that we are in the right plane. And when you open up from here to here, it opens up like a book. That is the beauty of it. So the PI is still there over the dorsal columns and over the corticospinal tracts. And so see the vertical vessels here, and I put a marker at 2 millimeter on my micro scissors, so I can see how deep my depth is. Usually we go 2 to 3 millimeters in depth, and the angle is naturally made, is around 30 degrees, and results are beautiful. This was till 2009, that pre-COVID it was so we had done 60, now we have crossed 100 cases, and excellent result, excellent to good result in more than 80%. So, and long term, we have patients coming in after 10-15 years, 2014, so it's 10 years already, and we have these cases, and this is the learning curve. Obviously, initially the most important complications you have because of retraction, you don't know what you're doing, finding the DRES zone. So you press on the, what I would say, corticospinal tracts. And there is a overlying, I'll just, it's moving on its own. So there's an overlying cerebellar tracts which may cause imbalance and temporary weakness. Coming to the lumbar DRES. Lumbar DRES is very rarely. Most of us for cerebral palsy do a normal, they don't do DRESotomy. They do, they cut the roots. Sorry? Yes, selective dorsal rhizotomy. So nobody does a DRES. So what I'm going to show you is a DRES at the lumbar level, which I think we are the only institution currently doing it. So standard prone position, and we do laminectomy from D12 to L2, and then we see the conus. The conus is visible, and we identify all the roots are there. We identify the S1 root because S1 root is the thickest root. So it's one of the largest. You can anatomically just see it by eyeballing it. Otherwise, if you want, you can use obviously EMG and then NCV nerve stimulator and find out if you have all that. But in a resource constrained setting, just by identifying the S1 root, you know that your lesioning has to be done or the DRESotomy has to be done up to S1. S1 doesn't need to be involved simply because S1, S2 will be subserving the bladder function. So we start from the L1. So L1 again you can directly visualize because we have done a laminectomy of D12 to L2. So L1, you see the root going into the L1 foramen. So you identify it visually, and from there you do the dress. So you lift up all the dorsal roots medially, and then you see this artery out here. This is the posterolateral spinal artery, and you go under it. So the dress, this is all the roots coming out from the posterior column. In the conus, it is extremely tight and crowded area. So you have to be careful, and you have to be careful that you don't injure it, this posterolateral artery. But if you're in the right plane, then you get very nice results. So this is what I'm doing the dress, and again you can see this is the vertical vessels which are visible, which are there. So if you do it, you can still see the vertical vessels out here, even in this lumbar dress. And then a standard closure. So you can do it bilaterally if there is spasticity, severe bilaterally. I usually do it one side, because even one side causes bilateral decrease in spasticity for some reasons. And so the same procedure affects two things. It causes decrease in spasticity, and it causes decrease in the pain. So that is the beauty of dress. So any kind of spasticity, severe spasticity, dress can really work wonders. If you do all those, all of us must be seeing traumatic patients who have gone into severe spasticity, upper and lower limbs. Again, upper spine, cervical spine and lumbar dress can be beautiful in these cases, and we have done so many of them. Post-stroke pain we have done. Post-stroke, neuralgias, upper limb, where they have severe pain. Again, dress can work. So it is a very low cost, I would say, and can be done in any center. You just need micro scissors and a microscope. And for a neurosurgeon, it's not a difficult thing. And you can add, selective dorsal rhizotomy if you really want to, just for certain, if there are some muscles which are very, very tense. So many advantages of dress. So this was in a nutshell rhizotomy, and I'll explain more in detail later. Any questions on this?
We demonstrated also in one of the workshops. Like it is always a group of nerves which are like this. We can't be specific.
You cannot be specific. If your question is from which level to which level we have to do, lumbar is fixed. Lumbar we do fixed. We have from L1 or L1 root we identify from, that is the superior limit, and S1 is the inferior limit. So we do it between that, because this is not for one level spasticity, it's for generalized spasticity. Even in pain, this is not for radicular pain or anything like that. It is for severe pain, which is regional pain syndromes, failed back syndrome, where patient has tried everything and the pain is excruciating. There we can think of a dress.
I think this is very good. Dress is one of the lost art in neurosurgery also.
Yes.
I mean, in US, Dr. Nashold after
Yes,
him,
Nashold.
no one does it. Maybe Mark Sindau used to do in France, and then Nashold. I think it's very good that you are doing it in teaching your residents, because this is the amazing surgery.
And very rewarding.
It's very rewarding, especially these flail, painful arms and
Yes.
brachial plexus injuries. This is an amazing surgery.
Thank you.
I would like to invite Dr. Ashwini Raj for stellate ganglion block.
देखना अजय भाई देखना. So very good afternoon, everyone. Actually, myself, Dr. Ashwin. I'm abhi like assistant professor in Department of Emergency Medicine at AIIMS. I'm very privileged to talk in a neurosurgery like conference about stellar ganglion bulk. Everyone will be wondering why an emergency physician is talking about stellar ganglion bulk. This actually it's a long story. Like my mentor professor, actually Dr. Boisa. So actually we had a case like it was during the COVID time. There was a patient who went into a cardiac arrest, like in front of our like emergency, like main emergency, and like we did everything. Like we pura like ACS algorithm kiya tha, like shock, multiple shocks given, amyotron given, sub cheese for but still patient was not recovering, and also he was also one of the staff of AIIMS only. So we were like thinking of what else can be done. Finally, Boisar decided to try stellar ganglion block, in which like the first attempt was actually he gave, and the patient's like electrical storm. Actually, patient was in like continuous ventricular fibrillation. So it's a electrical storm. It was to run aborted by like stellar ganglion block, and this patient actually survived and got discharged. Like he's still alive. That's the importance of the stellar ganglion. Iske baad we have almost like during that time I was just a junior resident. Like iske baad abhi last 4-5 years mein we have done stellar ganglion block in almost more than 20 cases in our emergency and have been successful in multiple cases. Many published works have already been there from our department. So I will be like quickly I will be going through the stellar ganglion block. Detail will be done in the coming sessions. Basically, anatomy of stellar ganglion block, basically it's formed by the combination, like it's a sympathetic chain formed by the inferior cervical ganglion and the first thoracic ganglion will combine together to form the stellar ganglion at the level of C7. It's over the longest colli muscle. And we have to target the like lignocaine, bupivacaine over the stellar ganglion to have the effect. And the first, it's always a ultrasound guided procedure, and we use a linear probe. Linear probe we will be using it over the cricoid cartilage level. At the level of the cricoid cartilage, we use a linear probe with the pointer towards the midline, and then we slide the probe slightly laterally. Then we get such a view in which you can see that this is the trachea. Then from there you see the thyroid, and there you have the carotid artery, the jugular vein, and here it's the C6 and C7 tubercle. Just above the C7 tubercle, you can see the longest colli muscle, and just above that it's the sympathetic chain. Actually, we need to enter the plane from laterally, and we should avoid the veins like major vessels like carotid and the jugular vein, and should deposit the local anesthetic at this level. So I have a short video demonstrating how this is done. Actually, actually we are also Boisar is actually along with Dimakar sir, we are doing it for patients in neurosurgery ICU for paroxysmal sympathetic hyperactivity syndrome also. This is one of such cases in which it was performed. You can see here here you can see the similar anatomy. It's the carotid artery. Here you can see the thyroid. Here it's the hyperechoic. This is the like C7 tubercle. Just above that, here you have the stellar ganglion. So you can Here you can see the needle is being inserted from laterally. Just slightly see the needle being inserted. Under the guidance of the ultrasound, the needle will be slowly inserted from the lateral side until we reach the point where stellar ganglion, where we deposit the local anesthetic, which can be lignocaine or bupivacaine, like 5 to 10 ml of lignocaine or bupivacaine, or the pre-vertebral fascia. You can also appreciate the lifting. You can see the needle being inserted. Here you can see the one anechoic shadow, which is actually causing the, like, first we like push around 1 or 2 ml of saline just to confirm it's not in the artery. Then we have to like push the lignocaine or bupivacaine. Then you will see there's an anechoic shadow here, which actually refers to the like lifting of the fascia. Actually, successful block. This similar thing was done in another patient, which was during CPR. That's why so much artifact. Here also you can see the needle tract. Same thing, how we enter the plane just below the carotid. Here you can see the C7 vertebra. And how we can confirm it's a successful STG is by like Horner syndrome. You look for signs of Horner syndrome, meiosis, ptosis, and heterosis, and lack of sweating in the area. And there can be nasal congestion, dilatation, and increase in temperature in the ipsilateral. Around one. Rest of the things will be discussed in detail the coming tomorrow and day after sessions. Thank you. Rectus spine also we will be discussing tomorrow. Actually, it can be electrical storm. Like if it is not actually reverting with the conventional ACLS, then we can consider this, like VF or VT.
I think this is one of those things, autonomic neuromodulation, that can be used for anything. Just like vagus nerve stimulations, now used for, started with epilepsy and then depression, and now they're saying for sleep. Same way for stellate ganglion block, we have used it for ARDS because we used it for autoimmune disorders, because autonomic balance changes, immunity changes. So fibromyalgia, there have been trials, stellate ganglion blocks for fibromyalgia. So you can find out indications for this. This is and it is not a local block. It changes the dynamics of the whole sympathetic system in the body. Just one ganglion block, because it's such a strategic location that you do a block and it changes the sympathetic tone of the body.
For CREST syndrome, it works wonders. Actually, when a patient is in acute CREST syndrome with digital CREST, a form of SLE where the patient is having digital ischemia, digits are going black. I'm sorry, it is the phone, but I can't show. But then the patient has improved dramatically, and the color has been restored, and patient improved even in the pain score also, because patients came with pain. And one incident happened is like, I'm sorry to say that we don't know what happened. One sister was saying like they have applied a tourniquet, forgot to remove it for IV cannulation, and then the limb went into ischemia, which maybe the patient was already having a compromised, because otherwise just by having a venous congestion, none of the patient will have an arterial ischemia. But unfortunately, the patient had an arterial ischemia. So even that patient improved after giving a stellate ganglion block. And the youngest child that I gave stellate ganglion block was a 9-year-old child. Not a surgical sympathectomy though. Surgical sympathectomy we are doing even for the newborns who are having an aberrant arterial connection, the aberrant pathways, who are having The children, even the day-old children also they are doing, but I have done for a 9-year-old with continuous atrial fibrillation, even after RF ablation of the brain pathway. It works actually. If any ventricular tachycardias or supraventricular tachycardias, it works.
So this is question to Deepak. So in a case of vasospasm, how do you select which side? And do you do a DSA prior to stellate ganglia? And suppose if you have bilateral vasospasm, then what is the strategy?
Questions. Actually, vasospasm we are getting very routinely with our post SH patients. So we usually do it on the side of the vasospasm. That is the standard thing. And vasospasm we are detecting by clinical deterioration. It is always clinical plus minus only, not angiographic, but TCD vasospasm. So TCD, if we find severe vasospasm, we can think of doing a stellate ganglion block as an interim measure. That is number one. If we are getting clinical vasospasm also and stellate ganglion is not working, then obviously we have to take for intra-arterial. But stellate ganglion works wonders. It can give us that time to tide over the crisis. With bilateral, we usually do not do bilateral. We do only one side. I would prefer the right side, but I think you can add to it.
We usually, if at all we are doing, we do bilateral. So provided EF is more than 45, because the ejection fraction is more than 45, because you're causing sympathectomy bilaterally, there are high chances the patient is going into hypotension. So heart should be able to compensate for that hypotension. If the heart is already compromised and the ejection fraction is already less than 45, that means like at least half, or like say 2/3, then the patient will not be able to tolerate bilateral sympathectomies.
Is detrimental. So there's a yes.
So what you're asking, one side, then
And after 2 days, we can repeat on the other days.
So simultaneously, you must not be doing.
Simultaneously, I do lesioning also, sir. Provided EF is
So
fine.
two different schools of thought. But as a neurosurgeon, because we are taught with that triple H therapy, so always hypertension has to be maintained.
Yeah.
Hypervolemia, all these
I mean,
things.
this is what I'm talking for this heart. You're talking about the brain. For brain, only on one side.
Only on one side.
Only on one side.
No, prophylactically, if there is vasospasm, on TCD at least. Also in head injury patients, we have seen there is one example where patient came as M1 and hypotensive and full doses of NORAD and all that. So they could not make a diagnosis, diffuse axonal injury. No. So we thought, because neurogenic cascade is a diagnosis of exclusion, there is no. So it was going on for 4-5 days, all these drugs. So we said, why don't we try stellate ganglion block? And after stellate ganglion, the patient improved, became suddenly M5. NORAD and all these doses tapered off. Unfortunately, he had to be amputated on one side because the noradrenaline was being given at such a high doses for a week or so. But none of us think that way for giving, when thinking that M1 patient could have a neurogenic crisis, which is not that uncommon in patients. And then the patient actually got discharged after a month or so, or amputated but discharged. Yes.
even non-vasospasm patient, cerebral blood flow, cerebral blood flow. And in COVID, we used to manage the ICU back in US. There is so many stellate ganglion blocks, and those patients who could see, patient himself was the control. One lung is getting more parameters of the other lung is
Not getting. Achha, excellent. So I think it's the next, panacea. No, not brainstem absent. Brainstem, nahi, but patient is M1 having repeated cardiac arrest on max dose, hypotensive. On max dose of all the normal NORAD, vasopressin, all these stuff. Thank you so much.
I would like to call the next speaker, Dr. Ilavarse. for Botox injection? How do I do it?
Good evening, and thank you to Dr. Rajiv Sharma and the entire neurosurgery team for having me here. So I'm a neurologist at AIIMS New Delhi, and I would be presenting a short video session on botulinum toxin in dystonia and how I do it. So botulinum toxin is the drug of choice for focal dystonias, and it has FDA approval for two indications, which is cervical dystonia and blepharospasm. But for many other indications like oromandibular dystonias and other focal dystonias like writer's cramp and task-specific dystonias like musician's cramp and other focal dystonias, it is the treatment of choice, and there is RCT evidence to prove that. Apart from that, we also use it in hemifacial spasm and hemimasticatory spasm, in which it is very effective. So we'll see some videos. This is a case of classical blepharospasm. You see the frequent blinking. And this is another patient who has asymmetrical blepharospasm, in which the right eye is less affected as compared to the left. So in the morning during the session, there was a question asked. So I would like to give a little bit of explanation, especially to Dr. Tushar and the others who were asking the questions. So when we are looking at the eye closure, the orbicularis oculi is the muscle that is involved, and the muscle has three parts: the pretarsal, the preseptal, and the pars orbitalis part. So when we are normally blinking, the muscle that comes first into activation is the pretarsal part, and when there is forceful eye closure, the muscle that is activated is the pars orbitalis. So especially in milder cases and especially in early cases, or in treated patients in whom there is already some residual effect left, in such patients just targeting the pretarsal part would be effective. The pars orbitalis is the strongest muscle, strongest closer of the eyelid, and not everybody needs to act on the strong, needs to be targeted for the strongest muscle for the drug to be effective. In fact, in those patients, if you target the orbicularis oculi pars orbitalis, it may not be effective because the muscle that is actually leading to lot of contraction is the pretarsal part. So if you see this video, I'm sorry, I may not be able to complete this, then in the tomorrow's session I can continue with it, but I think we need to go a little bit deeper into it to gain a more better understanding. So in this first patient, if you look at it, it is just eye blinking. The pars orbitalis is not acting that much. But look at this patient. Here you are able to see that this part, this so you can see that the orbital part of the orbicularis oculi is contracting. In such a patient, you will have to target both the groups of muscle. And in this patient, because the right is less affected, then we will probably give a little bit 1.5x more dose on the left side as compared to the right. So how do we do it actually? So this is a circular muscle as I showed. So in the pretarsal part, in these 4 points, we give the injections. So the starting dose is generally 1.25 units. We go up to 2.5 and sometimes in very severe cases up to 3.75 in each of these quadrants. And if it is even worse in that situation, then we target the orbicularis oculi pars orbitalis, in which we give at the 4 quadrants here, 1, 2, 3, 4, and also in the almost 1 centimeter lateral to the lateral canthus of the eye. So usually the total dose is up to 40 units in each eye, so this is the starting dose that we do usually, 1.25, and in some cases up to 2.5 as the starting dose depending on the severity. So what do we tell about the patients? We tell them about ptosis. But in experienced hands, as I told in the morning, if we go away from the midline and target the lateral edges of the eyelid, then you will be away from the levator palpebrae superioris and ptosis should not occur. Sometimes if it spreads to the other extraocular muscles, it can lead to diplopia. Local swelling and black eye can occur as complications, especially in older patients where the blood vessels are tortuous and dilated. People can get bad black eye or sometimes a subconjunctival hemorrhage as well. But in experienced hands, it is very uncommon, but it is essential that you tell the patients about this. And one thing that I learned from my mentor is sometimes the patients with blepharospasm, they come to you just before they have an interview or before they are going for a wedding function, and it's always a good idea to tell them to avoid injections very close to the special event, because if someone develops a black eye or something, then it is going to take time to resolve. So always let them know, because most of these patients are doing it for either because of social embarrassment. This may not be hemifacial spasm or blepharospasm, may not be that affecting the activities of daily living. So it is essential that they know about these complications, potential complications, though if you're an expert, it's not going to happen. Now let's move to cervical dystonia. So this is one of the patients whom I have seen who had a very severe retrocollis. She was having this, she was looking at the ceiling all the time while walking. And even when she was taking food, she had to sit against a wall so that her neck becomes straight, and she was suffering a lot because of this. She was having a very good response to botulinum toxin, but she had difficulty in affording the medication because each time her injection cost was somewhere around 20,000 rupees, even in the subsidized AIIMS setting. So we took help of our neurosurgeons, and later on this patient had a remarkable recovery. I'll show you in the coming videos. So this is how she used to have food. She had to sit against a wall and eat. And now let's move to the next video. This patient has a predominantly retrocaput. So as I told you in the morning, in the neck we have head and neck, we have two components. One is the head component, the other is the neck component. So here you see, so in the lateral view, we are able to see that this crease is there at the head level, at the junction between the occipital bone and the C1 vertebra. At that level, the head is tilted backwards. However, the neck is relatively straight. So this is a retrocaput as compared to a retrocollis that we saw in the other patient. So the muscle targeting is slightly different. So you try to target the muscles that predominantly act at the level of the head rather than at the level of the neck. So this is, the patient is being asked to do this movement voluntarily. So this patient is similar to the patient that I showed in the morning. If the component is predominantly the retrocollis, then I would tend to inject the splenius muscle more as compared to the semispinalis, which is the splenius is on the sides and the semispinalis is just parasagittal in the close to the midline. And in this patient, it is actually the opposite. So I would try to give the semispinalis more dose in this, but in this particular patient, because the patient also had this lateral turning of the neck, we had to inject the splenius also. So even though we are showing very straightforward patients here for videos for the sake of understanding, so that there is more possibility for everybody to start treating patients, but I would strongly suggest that whoever is interested in injecting needs to see more videos. There is a lot of literature available today on the internet, as well as we do conduct workshops frequently, and anybody who is interested in injecting cervical dystonias are strongly encouraged to use maximum available literature, because there is a lot of nuance to it, and cervical dystonia, to be very honest, is the most challenging forms of dystonia to assess and treat. So this is the patient that I showed you, but after treatment, this is how she looks. She is doing perfectly fine. This patient was operated by our neurosurgery team, and right now, actually she got lost to follow up because these patients, they do so well that they never come back to us. So we had contacted her telephonically, and they are from UP, and she is doing really well. This is another patient of mine who had a very, very severe form of focal dystonia as well as dystonic tremor. He cannot even speak because whenever he tries to speak, his tongue comes out. He has this orobuccolingual dystonia as well as a very severe neck cervical dystonia. And he has been following with me for the last 5-6 years, and he comes every 3 months, and this is how he becomes after he gets the injections. He actually, we had suggested him to undergo a surgical procedure, but since he feels that the toxin is so effective, even though it is quite expensive for him, he still comes every 3 months. So this is the recent video that he sent, I think in the second week of April or something. He is doing very well. So this is the pattern that I had used for him. So since he has significant lingual dystonia, so genioglossus is the muscle that leads to protrusion of the tongue, but since the deviation is towards one side, the right genioglossus I have dosed a little bit more as compared to the left. If the tongue is protruding exactly in the midline, then we would dose both of them symmetrically. But here, since the tongue is deviating towards the left, I have dosed the right side a little bit more. Similarly, there is a laterocollis towards the right. So for that, I am targeting the right levator. I'll show a chart in which how we do the muscle selection is mentioned. So this is another patient who has this anterocollis with jaw opening dystonia. So he has this problem of whenever he tries to chew something, especially something chewy like a paratha, he has a lot of difficulty in chewing because his jaw gets opened. And so you are able to see that his head is getting flexed over the neck as well. When he's speaking also, his jaw is getting opened, and this is him after treatment. ये audio आएगा क्या? Audio. Video. So short, you're able to see that his head flexion is completely resolved after injections. So this is another, we have various combinations. Basically, cervical dystonia, as I said, we have two planes of movement, one at the level of the head and one at the level of the neck. And then we have this turn, which we call either torticollis or a torticaput. Then we have a tilt, which is a laterocollis or a laterocaput. Then we have anterocollis, anterocaput, retrocollis, retrocaput. So in a single patient, you can have movements in multiple planes, and you can also have a phasic dystonia in which there is dystonic tremor and the movement is happening in multiple planes at the same time, and sometimes they are going out of phase also. So it is very essential that the patient is examined in multiple planes and then the dose selection is done. I think we are running out of time. I can continue with the talk in the next time. If someone wants, they can take a shot of this slide. So this is the core of our muscle selection, and maybe in tomorrow's session and day after tomorrow I can talk more about this in the interest of time. Yeah, maybe we can here and so in this patient, Botox is not needed, and this patient, what he was actually having was ocular myotonia, in which it's a myotonic disorder. There is difficulty in relaxing the muscle, so it appears as if it is. Differentials and before offering botulinum toxin. Facial synkinesis and ocular myasthenia also can be mimics, so we need to be careful. Rest I show in the next. Okay, this is selfie dystonia. Don't inject this. Thank you. Sir, we had offered pallidotomy, radiofrequency pallidotomy, bilateral. And after that, the patient came for follow-up. 2-3 visits the patient came. And after that, it was somewhere in the middle of COVID. But the patient is doing well.
You have to go back and study an admit and learn original instruction of formation before thinking about botulinum.
Correct, sir. Thank you.
I invite Dr. Rajesh Kanchandani, who is also going to talk to us about Botox, how I do it.
So good afternoon, everybody. Dr. Ila is a very seasoned campaigner here. I don't know, I'm speaking here on this stage. She's also smiling on the parameters that we were discussing for botulinum toxin. So I will have a different perspective. I'll try not to overlap because she's already done a lot. So when I say these are the programs that we do. This is one of them is Vinegoil, one is Petrus Vardia. So this is how we do workshops for neurologists and neurosurgeons. So as Dr. Ila said, you could actually learn this in our workshops and you can collaborate with us, and this is how we can take it forward so that you get more and more hands-on this. So that probably the outcome, it's not about injection, it's about whether you have got the outcome or no, which was the goal setting. So it's a goal attainment scale. So as we all know that we think about the Ashworth score, we think about the Tardieu score, we also think about the goal attainment scale, that is, have we achieved or has the patient achieved the outcome? It's not about the dose injected, it's not about what about the disability. So we'll discuss about all that today and tomorrow. So in 2 parameters. So when we say botulinum toxin, what can we do with it? Whether we can do movement disorders, that is blepharospasm, hemifacial spasm, cervical dystonia, or we can do pain management, approved irrigation, that is prophylaxis of chronic migraine. Now we have also got glands. So siluria for Parkinsonism, if you want to do the salivary glands by any chance, the submandibular or the parotid, or probably when you think about post-dose spasticity, we got approval of the upper limb with a blanket of the lower limb. And in pediatric patients, we have spastic diplegia, where probably we can do equanus foot is that it's just a equanus foot that we have got. Actually, we are doing a lot of indications. So equanus foot is one of them. So there are a lot of other indications like hyperhidrosis, axillary hyperhidrosis. Today one sir was telling me that I never knew that botulinum toxin could be used in hyperhidrosis of the axilla, of the palmar and plantar area. I said it can be used in scalp hyperhidrosis also. It's fine. Allodynia. Allodynia is one of the indications which we use. So the urology, overactive bladder, endio, bladder pain syndrome, interstitial cystitis, vaginismus, a lot of areas is coming up here, and GI is achalasia, cardia. So when we talk about, now Dr. Ila has already taken it, so I don't know how to do this. But this was a patient of retrocollis in movement disorder that we have, whether it works or not, I just want to see. So probably this patient was of a neurologist, I'll be very frank, in Nagpur. I've taken the consent and she had difficulty in breathing in retrocollis. She was on 10-liter high flow oxygen. So high flow oxygen, she was there in the hospital for the last 20 days. So there were 2 ways of doing it, injecting botulinum toxin and dry needling. So when I do dry needling along with botulinum toxin, she gets some relief in the next 24 hours. That's a temporary relief with the dry needling. And the botulinum toxin will inject the splenius capitis and the, of course, trapezius and levator if required. So in those cases, you get some relief immediately. The combination of dry needling with botulinum toxin is a very good combination. So you can try that, and if you see her after 2 days in the same hospital, but the funny part is even neurologist Dr. Ramtege says this is not because of bottom toxin. Bottom toxin will come later. This is dry needling effect. So you can try this also if the patient cannot afford bottom toxin. You can do this first. So this is not with bottom toxin. You don't get the effect within 24 hours. I mean, Dr. Ella will agree to what I am saying. So this is something I've tried new. So dry needling for poor patients with a 26 gauge 1.5 inch needle, 20 to 30 shots per site, and that works for the next 15 days till the bottom toxins start working. So it's a support system to the bottom toxin. So this is of course this is blepharospasm, hemifacial spasm. Dr. Ella has already taken that before and after. This is jaw opening dystonia. If you see this patient after 15 days was that this is what under ultrasound. So me and Dr. Ella was talking about ultrasound guided and CT guided. So this is how I do ultrasound guided injection for medial and lateral pterygoid for such patients with digastric problem. So this patient has done well, not too well, 40 to 50%. We are happy because she says I'm comfortable. So because this is happening since years. So she was on antipsychotics previously. So these are writer Graham's patient that Dr. Ella will be taking later. I'm not going to overlap. So I'm coming to spasticity. I'm so sorry. I was overlapping. I didn't know the presentation actually. So post-stroke spasticity is whether it's an acute ischemic stroke or a hemorrhagic stroke. There are different patterns of post-stroke spasticity. So if it is an acute ischemic stroke, usually if it is less than 1/3 of the hemisphere of the cerebrum, then probably you get the flexor deformity of the arm and the leg. If you see a patient, of course, all the neurosurgeons, I'm so lucky to have all the neurosurgeons here. Immediately when a patient gets stroke, the first thing is to think about removing the flap. Half of the patient, chalo, flap, remove, put pressure. But what happens after 3 months? There's a flaccidity of 2 months. After 3 months, you see this in acute smooth stroke. This is, what is it? I just wanted to show you the pattern. It's very important. I want you to see the pattern. What you see the patient as a surgeon, why I am coming to this topic is, when you see this patient on day 1 with acute ischemic stroke, okay, thrombolize the patient, neurologist does that. If surgery is required, fine, 15 days home. When the patient comes back after 3 months, you will find a flexor pattern. So adduction of the shoulder, flexion of the elbow, pronation of the arm, flexion of the wrist, flexion of the thumb in palm. This is a normal pattern in 70 to 80% of the patients. But in some patients in hemorrhagic stroke, you will get the extensor deformity. But when you go to the lower lip, you will get a circumduction gait. So what is the circumduction gait? Walking on the lateral border, that is a tibialis posterior. Usually the toes and the great toe, they go down, so you might have to inject the flexor hallucis longus and flexor digitorum for the toes. When it comes to the circumduction gait, you have to inject the gastrosoleus because R1, R2 shows you exactly how much has to be injected, 0, 10 or 20 degrees, whatever. And when you come to the circumduction, the first thing is high dose in adductor and low dose in ham. So which are the adductor? Adductor longus and brevis, high dose. Why we don't inject the magnus is because there's a gait issue. Unluckily, we do not have a gait lab in India. When I was in Harvard learning movement disorder for post-stroke spasticity, they had a gait lab over there. They exactly knew which muscle to inject how much. And sometimes this should say spasticity is good. So when you are injecting any one stump out of 3, never inject 2 stumps out of 3. Try to inject 1 stump out of 3 at a time. So if you are injecting high dose in the adductor and low dose in the ham, that is only for those patients who are bedridden. But if patients who are partially mobile, don't try to inject 2 stumps out of 3 in the thigh because you might get a waddling gait. So the question here is when not to inject was the question, not that I am going to tell you all that we are going to inject this in post-stroke spasticity, that. The question is when you have a circumduction gait, pick up the adductor first, but even if there is partial flexion at the knee, because that is because of the adductor, it's not because of the ham. So to be very careful to choosing the muscles. It should not happen that you made it worse. There is a lot of possibility that sometimes we inject full dose. Looking at the book, eventually it's about per kg body weight. Now I'll tell you the dosing. Actually, I'm going to do it tomorrow. It's a very interesting topic. It is either whole body per kg body weight or per muscle per kg body weight, male, female, with ethnicity. So we'll discuss this tomorrow. But today we'll talk about the patterns, flexor pattern, extensor pattern. What are the muscle flexion? Adduction. First muscle is pectoralis major. We can take the latissimus dorsi with that, but one muscle at a time. When I say flexion at the elbow, the first muscle we'll take brachioradialis. Everybody tells biceps. I said no. The hand is in pronation and biceps is a strong supinator. If you inject a very high dose in the biceps, it will go more in pronation, irrespective of you injecting in the pronated teres and quadratus. So the question here is which muscle not to inject was a question. That when you are injecting the flexed elbow, first inject high dose in the brachioradialis and low dose in the biceps and high dose in the pronated teres. Otherwise your hand will never come in supination. For the wrist, always do the flexor carpi radialis and the ulnaris for extension, extensor carpi radialis and ulnaris. For finger flexors, always remember the whole finger and the tip of the finger. When I say the whole finger, it's flexor digitorum superficialis. When I say tip of the finger, it is FDP, flexor digitorum profundus. You have to decide whether you have to do the finger or the tip of the finger. So you have to choose any one. If you are choosing two, power has to be 5. Now another question, when you are injecting too many muscles in the hand or the leg, if the power is less than 3, you have to choose. You have to choose which joint. Now the new protocol comes in that if the power is less than 3 in the hand, we will go per joint. We will not inject the whole arm because it will get worse. Because first line of treatment of post-stroke spasticity is physiotherapy, not bottom toxin. Bottom toxin lifelong will remain an adjuvant. So bottom toxin is an adjuvant and support system. I would never say that everything is bottom toxin. I am telling you physiotherapy is plain cast, counseling, as Dr. Ila said, multidisciplinary approach is the way forward for post-stroke spasticity. So I will just show you the patterns today. If you see, this is what we were talking about. If you see on the screen, flexed elbow, clenched fist, flexed wrist, equinovarus foot, plantar foot flexion, flexed toe, circumflexion. These are the patterns you will see in acute ischemic stroke. Now, when it is usually a hemorrhagic stroke, you talk about extension. Some patients get extension. And if you see the patients of acute ischemic stroke, these patients mostly 90% have flexor kind of format. Some with long term. So what is the period for best results of bottom toxin in post-stroke spasticity? 3 months to 9 years. It's written in a book in the US FDA guidelines. If the patient comes before 3 months, there will be more flaccidity. If they come after 10 years, probably the outcome is going to be very, very poor. So we start with dry needling and physiotherapy and cast with bottom toxin combination in such patients. So when we come to the, of course, symptoms, muscle stiffness, pain, everything is there, clonus. So what is the scoring that you are looking at? Before that, what is the physical therapy? So treatment is first line is physiotherapy, second is occupation therapy, cast and bracing. Bottom toxin is the last thing you can think of. When nothing works, then bottom toxin works. So never consider bottom toxin as first line therapy for post-stroke spasticity because that will become unethical. Even if we are from bottom toxin, we are very clear that the American Academy recommends bottom for treatment of paralysis. Actually, the last point here should be as the last resort. That's a fact. So when I say, of course, these patterns, if you see all the shoulder internal rotation, so you may have elbow flexion, extension. So in forearm, you will have supination and pronation, neutral. So you have different patterns. And if you see the wrist, flexion, extension, neutral, flexion, flexion. So these are the 5 patterns that you will see in different joints. So these patterns are very important to decide which muscle to target, what is the dose. So tomorrow we will talk about per kg body weight per muscle, that is 0.5, and we will go to whole body above 18 years, and we will talk about pediatric spasticity also. What should be those in pediatric and adult, and what is the age factor you are looking at where you should not inject. That is the very interesting characteristic tomorrow. Also, when I talk about the shoulder, elbow flexion, pronation, flex wrist, these are different muscles that you identify. So when you do Ashworth score or a Tardieu score, so Ashworth score and Tardieu score and goal attainment scale, the 3 parameters we look at, will finally decide which muscle you are going to target, what should be the dosing, what is the power in the hand and the leg, and that will decide how much dose you will give. So the less the power, less the dose, high the power, higher the dose, higher the Ashworth score, higher the dose, lower the Ashworth score, lower the dose. It's very clear This is clear. Like Dr. Eli said, cervical dystonia. When you see torticollis, contralateral stenomastoid, is ipsilateral splenic cavity. It's very clear. This will not change for anything. Even for post-hoc spasticity, you have to be very clear. What is the? So these are the three scores you are looking at: modified Ashworth score, Tardieu score, and goal attainment scale. These patterns will not change. And if you are looking at just an clinical evaluation and injection, you might do a blunder. So always follow guidelines so that tomorrow if there is a medical legal issue, you can justify that whatever treatment we have given is fair enough. So these are the scores. Now the last slide before, because I know I am short of time, we'll do it tomorrow. Dosing guidelines, we'll do it tomorrow. So which are the muscles? We were just talking about abduction, adduction. We are talking about the muscles of the upper limb. So tomorrow we'll speak about the dosing of these muscles for flexors and extensors, and how do we decide the dose? Do we decide per muscle per kg body weight, or whole body per kg body weight, or male, female, or 27 ethnic groups in India, or comorbidities? So whether to increase the dose or reduce the dose, that we'll see tomorrow. Thank you so much. Thank you. Dr. Ela, I did not overlap. I was very scared of this thin line that we have. And today I just changed the slides at the counter. I just saw, I was very, I'm very sensitive about, because Dr. Vinay Goyal has been our mentor. So it's a very common thought. Thank you so much, sir.
Any questions? I declare this session closed. Dr. Ali, take over.
I'm thankful to chairpersons Dr. Tushar Arora sir and Dr. Linga Reddy madam for chairing the session. With this we come to end of today's academic program. We can have a tea outside, and after that I invite you all for dinner at Faculty Club. It's in AIIMS campus just next to Director's office, Director's bungalow. So I invite you all for dinner. Dinner will start. All arrangements will be ready by 6 p.m. So whosoever wants to join early can join immediately after 6 p.m. Thank you all. Thank you so much. One more announcement. Tomorrow's program will start at 8 a.m. 8 a.m. sharp will start. It will start with a neuralgia session. So please come on time tomorrow morning so that we can finish early in the evening tomorrow. Thank you.
Namaskar.